A very warm good evening to all the ladies and gentlemen on the show. Today, our revered Dr. P C Mahapatra, he is a well-known, well-renowned doctor dealing in obs and gynecology and a teacher par excellence. So, continuing with his series of episodes on various topics related to surgery and other issues, we are having this 24th episode, which will be dealing with the hysterectomy. So the topics of today are choice of hysterectomy, selecting the routes, changing trends and changing techniques, surgical options, and then followed by tips and tricks. Now today we have another new thing to be added by Dr. PC Mahapatra in this, that he is going to guide us on a YouTube link which will deliver all the earlier and future whatever series will be coming from his episodes. They will be available on that. So with this, I would like to welcome Dr. P C Mahapatra. Sir, please start.
Thank you, Dr. Diwan, for introducing me again. And thanks all the team Juventus for this continuous teaching program. And I'm surprised we are now entering the 24th episode on the main theme of surgical options in obstetrics and gynecology, the tips and tricks, which I'm going to share every episodes. And today is another episode on 24th, and this episode is something unique for two reasons. One is a happy Holi to all of you. And in spite of Holi, I think you have all enjoyed the daytime and now evening sitting together, my viewers, for this program at 6 p.m. I think that's one important, so that I congratulate all of you and wish you all the social as well as academic, I think convey my best regards on these two aspects. Second important, I must thank the team Juventus for initiating this YouTube channel and access to all the programs, which from east to west and north to south, many of my fellow gynecologists, they are seeing that yes, we are interested in all the episodes, and that's why how can we get it. And thank you very much for opening this YouTube channel as a joint initiative of my hospital as well as for the Juventus. And everybody, every gynecologist, everybody can access this either through the link or through that YouTube. And for that also, I thank Team Juventus for the propagation of the educational initiative for all time to come. Well, I welcome all of you to this particular episode. And this is episode 24, again a Juventus initiative, surgical skill transfer and solving clinical dilemmas. Welcome all of my viewers, all of my gynecologists, fellows, the friends, the students, the grand students, and my colleagues and my lovable people around the world. I think for this particular teaching program and continuous program of E-Gurukul organized by the Juventus. Again, I bring greetings from the place of Lord Jagannath. Without these blessings, I am nothing. And this episode is dedicated to the Lord and divine knowledge bestowed on me and waiting for that. Well, now I request Mr. Alad, who is the brain behind this particular initiative, and particularly for this access and how YouTube channel and access, so that every gynecologist can access to all the episodes as and when required for that also. And I request Mr. Alad to say a few things, and because he is digitally very strong, I am digitally very weak, and that's why welcome Alad. You can speak something more, and welcome all the delegates.
Thank you so much, sir, for giving us an opportunity to be here on the program. I must share with all the respected and revered delegates that although PC Mahapatra sir has given us all the credit that this program is our brainchild, it is actually not so. It is actually a brainchild of Dr. PC Mahapatra itself. And so we sincerely, sir, thank you for giving us an opportunity to be associated with this program. That is point number one. Let us be very, we are very humbly accepting that. The second is that even the idea of launching a YouTube channel and distributing this information to all possible gynecologists who want to have an access to this was also initiated by Dr. P C Mahapatra sir, and therefore we initially started with distributing of pen drives to all those who required that information. But then there is a better idea that for expanding the reach of this knowledge, the expertise which sir has shared with all of us, I think so the best part is to have a YouTube channel which can be freely accessed across India, across the globe. So this initiative will really help propagate this immense knowledge which sir has given and parted with all of us. And second is that all those junior doctors who want to aspire knowledge but somehow are not able to get in touch with sir will also get a direct access. So this was a good humble kind of an intention, and we are very pleased at Juventus that we have been a part of this initiative. And sir, we sincerely hope and are sure that this program of knowledge dissemination will continue, and Juventus will be always willing to be a part of this initiative. Thank you so much, sir. Thank you so much. And best wishes.
Thank you, Mr. Alad. Thank you, Mr. Alad. Now, this is the link. And I request Dr. Diwan to explain, because he knows better about this link. He is a link between me and Juventus and you people. And therefore, I request Dr. Diwan to explain what is means by that.
Right. Thank you so much, sir, for giving me this opportunity. Basically, this is a link. When you click on this link, you will be having a menu which will lead to various topics. So you have to click on the topic or episode which is required. So each episode is having a specific surgery covered or a specific topic covered, which is related to the medication specific to that particular disorder. And Dr. Mahapatra has very nicely explained in each and every episode through his own experience, through his own journey, and through the various other teachers who had influenced his course of journey in this particular thing. But his own experience is worthwhile watching, and he's explaining each and everything while the surgery is ongoing. So this is a thing to be seen. It is really pleasing to see that such a revered teacher is giving us first-hand information about the surgeries. So, sir, I think this is a self-explanatory thing, and more than this link or the books which are available, it is you who make the difference, sir. Thank you so much.
Thank you, Dr. Diwan and Dr. Alad, for beautifully explaining everything to my fellow delegates. Well, coming again, this 24th episode, the topic of today, the theme remaining constant, the surgical skill transfer and solving the clinical dilemmas. Today, this topic is dedicated to a very important and a very common subject and a very controversial subject, choice of hysterectomy, selecting the routes. Day in and day out, all of us are doing hysterectomy. At every small hospital, big hospital, medical institute, everywhere, day in and day out, this is being done, practiced by gynecologists for that. But there are many controversies surrounding this, and especially the routes. I think these are all debates and controversies which I will share my experience and my thoughts to try to solve it and make it a consensus out of it. That's my main purpose for this episode in 24. So that's why from the beginning, I can say that why this episode? Why this episode? The episode because, as I told, hysterectomy is one of the commonest surgical procedures for a gynecologist next to cesarean section. Second, this particular episode, I will confine to the benign conditions in hysterectomy and exclude the malignancy, which I will take in subsequent episode about the malignancy. And we have already completed the prolapse, and I have already finished the obstetric hysterectomy or a peripartum hysterectomy, and the vaginal hysterectomy, non-descent vaginal hysterectomy in different episodes, which you can refer it earlier also. So that's why this particular episode, I will just restrict my talk to the benign conditions of hysterectomy. Now, third is the rational indication based on science, not and need of the patient. The need of the patient is a priority, and that's why scientific and rational indication, whether the properly indicated surgeries they are not, so we'll touch. Safety and minimizing complications is the priority. And therefore, when you look into any surgery, and particularly in relation to this special surgery like hysterectomy, first and priority is the safety of the patient and complications, minimizing complications and maximizing result. So this is our ultimate aim in any surgery, and more so in hysterectomy. Now the controversies arises, more of major controversies arises about the choice of routes, and that's why the selection of the routes, absolutely we must screen it and scan very meticulously to find out whether we are right or wrong, and then applying that particular route, whether we are doing the justice for that. Then about the late changing trends and changing techniques, the evolution, the history from earlier time to the present episode, present time, there are a lot of changing trends and changing techniques. As technology has come out, we have to change it as per the timing, as per the innovations, and therefore, what are those? We will just hint on that. Then another important controversy is about oophorectomy. Many people ask whether ovaries should be conjured or ovaries should be removed. I think that's very important thing, controversies point. It is not at your whim that you remove or keep it. There must be some scientific basis, which I will explain in this episode. And of course, I will just emphasize that the opportunistic salpingectomy, it has proved beyond doubt that by doing a salpingectomy alone, 30 to 40% of the serous adenocarcinomas of the ovary, which starts from the tube, can be prevented. And that's important part in all hysterectomy for benign indications, the removal of the tubes. Then skill is important. For all these, one requires a skill. And therefore, one should be skilled in all the varieties, all the routes of hysterectomy. If one skilled in particular route, I think he will be biased. So unbiased practice in there. And in science, there is no dogma in science. And of course, the future, we're all changing day in and day out. We have seen changes and we expect the changes in the future also. And what are the future thoughts? Today, in this millennium, what is there? In the next millennium, there will be a drastic change when innovative things come out, and science is like that. And beginning of innovation is a fantasy. So think of it. I will request all the viewers to think in a different way and go in a different path. And the youngsters will think much better, because the innovations starts from the fantasy. The thoughts, the thinking, I think that you realize into your practice and found out new innovations, so that this episode will be obsolete after 20 years when the people will start a new innovations for hysterectomy. Now, therefore, the flow of events. I'll just start with the hysterectomy, the hard facts. Then second is the status. What is the status of hysterectomy in the present millennium? Then the different types of hysterectomy, the routes of hysterectomy, which this particular episode is mainly targeted for, and selecting the routes of hysterectomy, which is most ideal. What are the changing trends? What are the changing techniques? And we cannot ignore evidence. It must be an evidence-based practice. So whatever is experience-based practice has to be there, but more importance has to be given on the evidence-based practice. And then last, which the controversial thing, I will try to bring into a consensus, whether ovarian conservation versus removal in benign, in the hysterectomy in benign conditions. Before going to the subject, I salute these scientists, these innovators who have toiled their life and for the whole cause of hysterectomy. Ephraim Magdwell from Kentucky has started doing a first recorded hysterectomy, but ultimately it came out to be a patient cuffed and a large ovarian come out to be then. Ephraim Magdwell, and hats off to James Merriam Sims, who has a lot of contribution for not only hysterectomy, but various surgical procedures in the field of gynecology. Howard Kelly, one of the thinkers, one of the genius in the field of gynecological surgery, and Charles Clay, one of the again innovator in hysterectomy, Conrad Langenbach, founder in the vaginal hysterectomy, when the pre-anesthetic era, when the suture was not there, when the transfusion facilities were not there, when aseptic technology was a concept was not found. I think credit to these persons where they were initiated the process and gave us the idea of how to do a hysterectomy. Coming to the history, the first reported elective hysterectomy successful through vaginal approach is Conrad Langenbach way back in 1813. Before that, there are some instances, some surgeons or some innovations and scientists having done that, but it is not a successful. Either there could be a mishap. I think they couldn't survive in the initial post-operative period for that. And this is the first reported case. Now, Charles Clay was credited way back in 1863 for his first elective abdominal hysterectomy. And therefore, he did a subtotal hysterectomy because the main problem of the total hysterectomy, that beyond the uterine, while removing the cervix, there are hazards. The controlling the hemorrhage is number one, and then the urological problem, damage to the ureter, injury to the ureter and the bladder. And that's why Charles Clay became very, very tricky in doing a subtotal hysterectomy and suturing the whole of this stump in the cervix along with the vessels in one big stump. First laparoscopic hysterectomy, Harry Rich, way back in 1989, first started with the LAVH. Lap-assisted vaginal hysterectomy was initially conceived by Harry Rich in 1989. And then he modified after 4 years to first TLH, the total laparoscopic hysterectomy, way back in 1993, which our now present day generation of gynecological endoscopists becomes a target. And they think that when TLH I can do, I can be a good endoscopic surgeon for that. So TLH, Harry Rich, is contributed for laparoscopic hysterectomy. And of course, the gadgets are evolving. The new technology is evolving. Robot, everything now depends on the roboting. And the first robotic hysterectomy was started in 1998. And till date, there has been a lot of debates regarding the robotic hysterectomy in benign conditions, which I will explain in the next couple of minutes for that. Now, today's innovations are tomorrow's history, and one can only hope that the surgeon of the 21st century will not judge us too harshly and will realize that we are captives of the time in which we practice. And therefore, all surgeons are captives of the times in which we practice. Whatever available at that particular time, one must propagate. And hats off to all the surgeons of the yester generations, yester decades, yester years, and all hats off to all of them for their sacrifice for that. Howard Kelly, way back in 1912, told it was notably anesthesia which robbed surgery of its horrors, asepsis which robbed it at its dangers, and cellular pathology which came as a godsend to enable the operator to discriminate between malignant and non-malignant groups. And imagine from the past scenario how we have evolved. The past scenario of hysterectomy, no anesthesia, no diagnostic gadgets or armamentarium, only 2 fingers, 2 eyes, and 2 cerebral hemispheres of gynecologists. No knowledge of asepsis, no knowledge of blood transfusion, lack of instrumentation, no hemostatic measures, and survival is a big question mark. But the surgeon's will rather than the surgical skill, the willpower of the surgeons and the commitment to do that was the past scenario of hysterectomy. The present scenario, the advances, the diagnostic armamentarium of the pathology, starting with the imaging technology from sonography to color Doppler to CT, MRI, and many, many diagnostic armamentarium has evolved in the component of the diagnosis of the pathology. Profile of the patients have changed, profile of the physicians have changed, and profile of the places have changed. The profile of the patients, all literate patients, they know everything about that. And therefore, they know, they consult you before, after consulting the Google doctors. They're well known everything about that and come to you. So it's very important to know the sentiments and the thoughts of the patients also, because their participation in the process of hysterectomy, in the selection of the route of hysterectomy, cannot be ignored for that. then the physicians also. The present scenario, there are a lot of advances. The genius surgeons have come out with the technology. And way back, we people were surgeons of the yesteryears, where we are doing a hard work. We believed in hard work surgeons. And now the smart surgeons and smart work surgeons have replaced the hard work. But both things should be complementary and combined, smart and hard. And of course, the places. Gone are the places where we're a little limited to the medical institute, medical colleges, or a big hospital for that. Now, from smaller to a big hospitals in a corporate sector, and very hi-fi hospitals also available. And that has a lot of change in the process of the system of hysterectomy. Improved anesthesia. Anesthesia has been improved a lot, starting from the monitoring, to the drugs available, and from the tube to the ether anesthesia, open anesthesia, ether anesthesia, to the regional anesthesia of spinal. We have come out about epidural. We have come out with the spinal with the 29, 30 gauge needle, and about the LMA technology, which is there, the laryngeal mask, and the monitors. I have seen in my early days of practice, even without monitor and without the gadgets of the clinicians, the anesthetist, hand and pulse, skipping over the pulse of the patient, I think they were monitoring that. There's a lot of changes, and that is mainly for the outcome. Blood transfusion facility has been improved, and therefore it could be a preventive as well as a therapeutic element for that. Knowledge of asepsis, we always target for that. Knowledge of surgical anatomy and reproductive physiology. This all gynecologists have it and must be revived. They have read the anatomy, but the surgical anatomy is little different from the anatomy days which you have seen in the undergraduate career in the first MBBS. The equipments and gadgets. There is a lot of reformation, changes. Day in and day out, we are finding the equipments and gadgets changing. And starting from the conventional equipment also to the endoscopic equipment, there is a lot of change, starting from the hand instruments to the vision, from analog to digital camera to 3D to the robot. I think these are all equipments and gadgets is going to influence the hysterectomy modalities. Of course, the fundamental and most priority as far as the result is concerned, as far as the quality of the surgery is concerned, is the surgical skill and training. And the skill cannot be overnight. The surgical skill in a particular technique, I think it will take a long journey, and it will take a hard work and toiling for that. And therefore, this is the most important worth of a professional. The most important worth of a professional is acquire a skill. Acquire a skill and forget everything. You will be the masters in it. And day in and day out, there is a changes. And you have to update your skill also. Whatever skill you have acquired it about 5 years before, you must update the skill according to the dynamic changes in the different setup for that. And of course, the computer and electronic era, bioengineering, then coming in the artificial intelligence will incorporate into the surgical field. And we have to be abreast with that. We have to be up to date and make at par with that particular thing. Otherwise, we will not grow. And of course, the technological innovations, there is no limit of the technological innovations for that. But same thing, tech and touch blend is necessary for that. You cannot ignore the touch also when technology has come out for that. Now, Dr. JMT Fani has given what are the reasons to operate for any surgeries. Valid reasons to operate is to save life, to relieve suffering, to correct significant anatomical abnormality, and allow for creation of life. I think when hysterectomy is concerned, the first and second is most important, to save life and to relieve suffering. This is the main concept why you operate for that. Now, these are the hard facts. Hysterectomy, again, I say that the most common operation performed by gynecologists as well as surgeons all over the globe, and India in particular. It's not the gynecologists are doing hysterectomy. It is the surgeon, general surgeons are also doing hysterectomy. And it is the second most common major surgical procedure in females next to cesarean section. As for the statistics and prevalence goes, 6 lakh hysterectomies per year are done in USA. 30.4 per 10,000 women in UK undergo hysterectomy, and 1 of 3 deprived uterus by 60 is in United States of America. And Indian statistics as usual, a big question mark, because the documentation is very poor in our country. And I hope that is much more than the standard reference by the Western countries for that. Now, basic concept of any surgical procedure and hysterectomy in particular, first, selecting the right patient for operation. That's important. And therefore, the indications must be absolutely genuine. Now, if we select the right patient, and if there are 3 or 4 modalities of surgery, like this particular case, the choice of routes, we have got different modalities of surgery for that. You have to select the right modality for that particular patient. It cannot be for one procedure for everybody. And therefore, there are various methods, and the patient's profile is different, the pathology is different, and the physician profile is different. And therefore, you have to select the right operation for the patient. Then third comes is the performing the operation correctly, the skilled technique-wise, it must be absolutely correct. Whichever modality you do it, the skill is important for that. If these 3 are really dealt with, I think you forget about the 4th, post-op care. You forget about the post-op care. If you do the surgery very skillfully, I always believe that one of the most important post-operative care is a good piece of surgery. Do it and forget it. And that should be the principle for that. You devote little more time during the surgery intra-op period rather than pondering your head every day after the surgery. I think that should be the motto of all gynecological surgeons for that. And apart from it, in subject of gynecology, and more so when a pelvic surgeon like hysterectomy one is doing, the knowledge and understanding of physiology of reproductive organs, pathology, and clinical manifestations of the pelvic disease and dynamics of psychosocial and sexual development is mandatory. Particularly in a women's health, when women are particularly need that psychosocial and sexual development. Now, status of hysterectomy. What are the key issues? First, what is the status of uterus to be removed? That means, what are the indications? What is the status of surgeon who is doing it? Third is status of route of removal, which is our concern today. And fourth is status of changing trends in techniques, whether there is a change in techniques or that. In this heading, we'll discuss that. Now, status of uterus to be removed. An anonymous statement told that what is the indication? What is this? What is the status of uterus to be removed? The sole purpose of uterus. What is the sole purpose of uterus? Is procreation and creation of diseases. So once the procreation is over, why to wait for creation of diseases? Remove it. This is a terroristic approach of doing a hysterectomy. Presence of uterus is an indication of hysterectomy. That is to be banned for that. There must be valid reasons to operate. There is a valid indications to operate for that. Status of uterus to be removed. These are some of the indications which I'm telling you, particularly the long list of the indications of hysterectomy, the uterine pathology. Number one, very important is the uterine pathology. And out of these, in benign conditions, in uterine pathology, it must be benign or a malignancy. And I will restrict my talk today into benign conditions. When benign conditions are there are some prominent major factors in uterine pathology, like abnormal uterine bleeding, the leiomyoma uterus, the adenomyosis, and these are the main 3 components, commonest indication in the benign conditions in the uterine pathology for that. Then cervical pathology, again a benign, like forget about the cervical carcinoma, but the initial phase of the CIN, anal the cervix, and these are indications for the cervical pathology where indications are there for that. And adnexal pathology, in the ovary, when there is an adnexal pathology, the tube ovarian mass, and particularly for the endometriosis, becomes a very common thing next to the other 3 conditions where this is very important. And it could be associated with adenomyosis, or it could be alone, the ovarian pathology for that, and particularly for benign. Pelvic floor pathology, the prolapse, which I have already dealt with in my previous episodes. The obstetric pathology, like a peripartum hysterectomy or post-abortal hysterectomy, which I have covered in my earlier episode for that. Now, then is the disease of adjacent organs. This is again, when there is a carcinoma of the rectum, our surgeons tell that you clear it, even if the uterus is innocent and normal, you clear, you do an anterior removal, then only I will do an APR procedure for that. And this is also implied. Sterilization, hysterectomy is a sterilization method, was initially tried in United States, which was accepted initially, but now we don't think that sterilization method, we should do a hysterectomy for that. And one of the very, very unusual cases of chronic pelvic pain, CPP, a patient complaining of pain in the lower abdomen. It is thought that it could be due to uterus, and we removed that, the chronic pelvic pain. And you just imagine, without any pathology, no pathology, uterus is being deprived and hysterectomy is being. So these are all unинdicated hysterectomy. A patient, suppose a simple example, a menopausic cycle for 3 months, 35 years old, completed family, and absolutely everything is normal, but do a hysterectomy. I think these are all without any pathology, and these are all unbiased and irrational indications for that. Now look more into it, how the uterus is being sacrificed. The uterus is innocent, and how the innocent uterus is being sacrificed for that. Uterine pathology, simple, the presence of the myoma, you do a hysterectomy, asymptomatic myoma. There are a lot of asymptomatic myoma which is being done. Adenomyosis, abnormal uterine bleeding. There are some alternative things for that. You can try. Abnormal uterine bleeding, the endometrium is defective. And instead of attacking the endometrium, you are removing the myometrium, whole of the uterus, you are removing the cervix. How justified you are. So therefore, the alternative things must be searched for, whether there is an indication for a medical management or a Mirena or a drugs, the medications, or also alternative very safe methods of destruct the endometrial ablation, either hysteroscopic ablation or a thermal ablation. This should be thought of instead of going for hysterectomy. Cervical pathology. Again, in benign cervical pathology, some uterine saving procedure and the cold knife biopsy, the cauterization, the LTTZ, these are all alternate procedures which should be adopted. And instead of that, we are removing the innocent uterus. Adnexal pathology. Once upon a time, when there was an ovarian tumor in a perimenopausal age group, the commonest practice was doing abdominal hysterectomy with bilateral salpingo-oophorectomy. Now, the gadgets are there to detect preoperatively regarding the malignancy, possibility of malignancy. For example, the color Doppler, the biochemical estimation of the tumor markers can see that whether they're benign or not. If they're benign, I think about it. And for adnexal pathology of the uterus and a benign pathology of the ovary, why the innocent uterus would be sacrificed. Again, the pelvic floor pathology, if there is a prolapse, I think who is at fault? The uterus is not at fault. The supports of the uterus is fault. Instead of uplifting the support of the uterus, we are sacrificing the uterus. How justified we are. And there are obstetric pathology where the conservation methodology should be there before attempting to a hysterectomy for that. And first is the sterilization method. It should not be used for that. And the worst is this chronic pelvic pain. Yes, I agree that in the case of pelvic inflammatory disease, where a pelvic adhesions are there, or there is a tumor, or there is an infective component, and it's a failure of medical management, you must do it. But any pain abdomen, could it be a cystitis? Could it be a vague pain? Any pain abdomen, you think that is uterus, and how justified you are. And of course, without any pathology, the uterus is being removed. Think about that before going for any choice of route of hysterectomy. Whether this particular patient is having an indication or rationality for hysterectomy or not, that you think about it. Dylan has told, the ease with which the average hysterectomy may be done has proven both a blessing or a cost to womankind. There is no doubt that a hysterectomy done with proper indications may restore a woman to health and even save her life. However, in the practice of gynecology, one has ample opportunity to observe countless women who have been advised to have hysterectomies without proper indications. I'm inclined to believe that the greatest single factor in promoting unnecessary hysterectomies is a lack of understanding of gynecologic pathology. The greatest need today among those who are performing pelvic surgery is a better knowledge of gynecological pathology for that. And therefore, before choosing the routes of hysterectomy, first of all, think that whether this patient needs hysterectomy or not. That has to be elaborated, that has to be introspected, and that is to be very, very judgmental for that. Status of surgeon. The gynecologist versus surgeon, general surgeons. The general surgeons, after the laparoscopic technique has come out, and they do a lot of abdominal hysterectomy beforehand. But when laparoscopy has come out, they're prominent. They're doing a lot of a laparoscopic hysterectomy. General surgeons are there. And more so when the wife is a gynecologist and the husband is a surgeon. I think the wife brings the patient and the husband operates for that. This is a common situation which I have observed in the whole of India, in every nook and corner. And therefore, I will request all the gynecologists to be very skillful and dedicate for that. And you are very, very worthy, and you are lucky enough to have your surgical partner as a husband, and he will come out when you are in a difficulty for that. When you are having some surgical problem, he will help you. Otherwise, you develop your own skill and do the hysterectomy yourself, because you know not only the surgical anatomy, more about the pathophysiology for that. And adequate knowledge in surgical anatomy and more than adequate knowledge in pathophysiology is important in a pelvic surgery, and more so in hysterectomy. And surgical skill and commitment and expertise should be there. You acquire expertise in the different techniques for that. Even the 3 routes, you must be expert in all the 3 routes so that the dogma will not be there. The setup, the gadgets, and the team. You must be a team leader. And that's why in one of my episodes, I've devoted more into the team and tool, the gadgets and team. Team and tool are understanding, and one whole episode is dedicated for that team and tool, the last episode. And ethical, rational, and human. Then coming to the status of route. The 3 main routes we know: vaginal, abdominal, and laparoscopy. I just imagine, recollect one of my professor of anesthesia in the OT while I was just doing this surgery. After finishing, we had a cup of coffee, and he told, well, you gynecologists, we have seen it for long years that you are removing the uterus by vaginal route, you are removing the uterus by abdominal route, you are removing the uterus by laparoscopic route. So I am just dreaming when you will be removing the uterus by rectal route or oral route or any other special route for that also. That becomes a fantasy. That could be possible without any routes also. You can remove the uterus for that. Now, what are the different types of hysterectomy? Let me brief you. You all know all these. Just summation and give an emphasis for that. I'm just putting forward for your orientation. The types of hysterectomy is either abdominal, laparoscopic, robotic, or vaginal. In the abdominal, the conventional laparotomy, day in and day out, you people are doing it, and either with the fun and still incision or with the longitudinal incision, you are doing it. The conventional laparotomy, we have done that. The second important, which I will just focus, the mini lap. I have some experience on this mini lap hysterectomy. Way back in 80s, late 80s, and the beginning of 90s, when the laparoscopy has in a preliminary state, and when my experience, I'm not very conversant about the non-distant vaginal hysterectomy in 80s, which I started developing in the early 90s for that. And therefore, at that time, I thought one main principle, one anesthetist told me that the postoperative pain and discomfort is directly proportional to the length of the incision. And therefore, I thought that if you can give an anesthesia and relax the whole of the abdomen, I can remove the uterus and reduce the size of the incision to 5 centimeters. And therefore, for years together, in particularly cases of abnormal uterine bleeding or maximum the uterus is up to 12 weeks, we do practice mini lap surgery with 5 centimeter incision. And at that time, till today also, the definition of the mini lap hysterectomy, the definition, it should not cross 7 centimeter. Optimum length, if it crosses 7 centimeter, it doesn't fit into the component of the definition of the mini lap. But I say that when the vaginal came and the laparoscopy came, I think the incision, even it is much better as far as the postoperative recovery and the comfort and the satisfaction of the patient. So mini lap now we have almost obsolete. Now in the laparoscopic variety, I'm seeing the evolution of laparoscopic hysterectomy. And initially we were very, very fond of doing a laparoscopic assisted vaginal hysterectomy. LAVH is very close to my heart. And LAVH, we do it, Harirech has proposed this LAVH. And LAVH is very good in the sense that the concept and idea is very good. While doing a laparoscopy, you see the most, if you go from the laparoscope from above down, by laparoscopy, it is very easy to reach up till the uterine. then the problem starts. After the uterine, the problem starts. And all the complications, the skill is more required for that. After the uterine from above. And from below, if you have vaginal hysterectomy, it is very easy to go up till uterine. And then the problem starts. Then there is a difficulty. And therefore, the concept is these two concepts, basing on these two concepts, the concept of laparoscopic assisted vaginal hysterectomy has been devised. And therefore, the initial adhesions and all the adhesions, endometriosis, you just release it and then do it from below and combination, so that the timing is less, with the less operating time, with less complications of urinary tract, and this you can combine and a good result for that also. Now then, the concept of TLH has come out with the proposition of again Hariraj, who have devised the LABH concept, which is now very, very popular for that. Everything is done from above, the total laparoscopic hysterectomy. But it's not total laparoscopic hysterectomy. I always say that it's also a marketing gimmick. It's a very popular, so that people will be really astonished by that. But the removal, whether the removal of the uterus is by that through the vaginal route. So you just do it from above everything and remove the recover the uterus through the vaginal route, and you stitch it from above or stitch it from down. The preference is yours for that. And TLH has become very popular. Until today, it is very popular. And that's why I also promote TLH. But my concept is that the TLH, when it is to be done, I think everything should be done from above. So you do a morcellation and remove it from the above. And particularly in some circumstances, this is very vital. This is very important of doing a TLH in some circumstances when you cannot deliver it from below. And therefore, then the power morcellation came, the concept of morcellation and the risk of malignancy came forward. Even if you think that it could be benign, it could be malignant for that. So then the changes in bag morcellation for that. So according to the changes, we are going stepwise and in bag morcellation and removing everything from above. Instead of that, you very easy to remove it, either the morcellation or debulking from below for that. That we'll discuss again while dealing with the TLH. Supracervical hysterectomy has been proposed by United States, many of the surgeons, because number one is that the complications are reduced to a great extent and the purpose is being solved. If you remain the intact cervix, I think the problem of bleeding, the problem of the urinary tract, particularly the bladder and ureteric injury, are considerably less, and it's a very easy procedure for that. It's a very simple procedure, surgical procedure for that in comparison to the TLH. And in addition, there have been a sexual satisfaction, the orgasm and all that have been added to that. We'll discuss again what the evidences say about the supracervical. Mini laparoscopy, as we are doing with the 10 millimeter, now many surgeons, including me, have changed from 10 millimeter to 5 millimeter. Unless the 3D is being used, we do not put 10 millimeter. With 5 millimeter, with 3 ports, 2 ports on one side and the main port, the 5 port. With the good camera, HD camera available, we can do the procedure. And again, people want that still reduction of that 3 millimeter port and again mini laparoscopy. At least if we use a 5 millimeter telescope, the side port could be 3 millimeter and mini laparoscopy could be used for that. The proponents of the single port laparoscopy have also tried many of the cases of single port, but the evidence, let us see what are the implications of the single port, the advantage and the disadvantage for that. And then the robotic. Robotic is one step ahead of laparoscopy, and this has been very promising earlier days when robotic has started. And there have been a lot of review after the 2 decades of review of robotic hysterectomy. Now the evidence is something different, which I will just narrate for that. And of course, the age-old vaginal. So vaginal hysterectomy was the first to be started, and therefore gynecologist is the signature of the gynecologist. One cannot ignore the vaginal route, and the benefits are more than the laparoscopic route for that. So therefore, the types of hysterectomy: abdominal, laparoscopy and all the varieties of laparoscopy, and robotic and vaginal. These are the 4 different routes of hysterectomy. We have to select which route is more suitable and ideal for which patient for that. Because when your only tool is a hammer, every problem will look like a nail. So therefore, If a surgeon is conversant with all these procedures, he is the best judge to find out which is best for which of the patient. If one is dogmatic about only vaginal, he will detect in all cases will do it vaginally. Only laparoscopy, he will try to do all TLH for that also. Or only doesn't know anything, abdominal, age-old practice, he will continue to do an abdominal. And this is not science. This is not rational for that. Now, coming to the details aspect of it, what is abdominal hysterectomy? More than 80% is performed in UK and USA, and it is technically easier. Access and visualization of abdomen and pelvis, enlarged uterus, adnexal pathology, previous pelvic surgery, and pelvic pain, and more of convention and practice. If you see the statistics, the incidence of abdominal hysterectomy, vaginal hysterectomy, and the laparoscopic hysterectomy, there is a declining trend of abdominal hysterectomy in favor of minimal invasive surgery, but still the figure, the abdominal hysterectomy is the heads the top. Then there is an increase in the incidence of laparoscopic hysterectomy, but the vaginal hysterectomy, the incidence is static. It is not being increased, though we find many of the increase in that. I think we must introspect why it is so for that. But there is certainly the advantage over the minimal invasive surgery of vaginal hysterectomy and laparoscopic hysterectomy over abdominal hysterectomy. So now the question comes, if it is due to convention and practice, if a newer modality is coming forward, are we going to say that abdominal hysterectomy will send it to the graveyard? I think we must review that, whether we can send it to the graveyard in the present circumstances of the technology and the skill available with us. What are the vaginal hysterectomy? What are the advantages? It is one of the oldest recorded in history, familiar with the gynecologist because of the signature of the gynecologist. Reduced mortality and morbidity. Obese, elderly, and high-risk subjects is more of benefit, rapid recovery, shorter hospital stay, minimal blood loss, minimal instruments, minimal complications for that. And vaginal hysterectomy, what are the disadvantages? No glamour, no money, surgery of minutes rather than hours. It's a need for good anesthesia, light, and assistant. It's difficult to learn and a challenging situations, need for meticulous surgical skill and non-complacency. And those who do a vaginal hysterectomy don't think that it's a blind procedure. Never a blind procedure. If you think that's a blind procedure, you are going to do a lot of complications for that. Now coming to the laparoscopic, the scope is broadened day in and day out. It has increased the laparoscopic approach, and patients' preference is also there for that because they are oriented for that. Scope is increasing. And the classification, the definition, starting from the Jones and Jones definition of different stages, stage 0 to stage 5, from just inspection, laparoscopic visualization to the complete procedure of TLH, stage 0 to stage 5 in the different stages we have done. There are merits over abdominal hysterectomy and vaginal hysterectomy. The types I have already enumerated. What are the different types of laparoscopic hysterectomy? When you go for a laparoscopic assisted vaginal hysterectomy, optical uterine is going for the laparoscopic assisted vaginal hysterectomy. You go it, relieve it the adnexa, upper pedicle, and reach up to the uterine. When the uterine artery is dealt from above, it is known as a laparoscopic hysterectomy. And when everything is done from above, you go for the terminology of TLH. This is the classical definition of the different types of hysterectomy, laparoscopic hysterectomy for that. And the technical aspects we'll just discuss. Advantages, disadvantages, complications, and future we must analyze with the evidence compared by the different agencies. Other key issues, subtotal versus total, LVH versus TLH, ovarian conservation versus removal. I will just enumerate in detail. And there are some changing techniques, clamp versus clampless. Earlier our teachers were using clamp, now clampless, or suture versus sutureless. I think this has been very, very close to my heart of sutureless. For the last 18 years, I'm using this particularly sutureless technique for that. Stage versus joint procedure. And if there are two elements, say for example, in one case, we'll have a symptomatic the gallbladder lap call along with the hysterectomy symptomatic ideal indications. We can do with the same procedure, with the same, so there's the advantages for the patient, beneficial for the patient. And of course, completion versus conversion. You are doing a procedure. Suppose you are doing a laparoscopic procedure or a vaginal procedure. In case there is a problem, you convert into abdominal. I think there is no ego in science, and you must be very free. That is a conversion. You don't think that I'm inefficient. So that's why I'm converting. No, it's not like the safety of the patient, the life of the patient is much more important. The complications are much more important. You sacrifice your ego for the betterment of the patient. Now, therefore, today's main discussion today will be selecting the route. How to select the route? What are the factors that come in while selecting the route? I have told about the different routes, the abdominal route, the laparoscopic route, and the vaginal route, and of course, the robotic. What are the factors that determine the route? Patient profile, physician profile, what is the pathology there, pre-op assessment and planning. Pre-op assessment should be done for factor selection, and where you are doing, place and provision, whether in that place, provision of necessary facilities are there also for that. And of course, you must have a skill. If all these 5 P's are met with, then you remember this 5th P, the PC Mahapatra for that. Patient profile. Now the patient profile, the obesity. Obesity now very often we find this is a common association nowadays with the obesity. In obese patient, you decide which one is best, whether the abdominal or the laparoscopy or vaginal. I think there are a lot of demerits of abdominal in obese patient for that. And therefore, we should think of other options for that. Parity, of course, the parity, the vaginal is much more favored for that in the paras vaginal delivery for that. Although we say that cesarean section is not a contraindication for vaginal case. Previous surgery or surgeries, there are many people who have undergone different surgeries. A number of times he has undergone surgery, particularly in a case of endometriosis. Couple of times he has done laparoscopic surgery, then laparotomy also has been done. Then patient still is not cured of the disease and persisting symptomatology, where the decision has to be taken in favor of the safety, whether to go for a abdominal or go for a laparoscopy, depending on the skill. You should find out. Concomitant surgery. You are going for a concomitant surgery, doing the 2 surgeries at the same time. I think this has to be associated, find out. Then other associated, other than the gynecological conditions, the associated medical conditions, precluding the anesthetic technique. This is also important. Patient is interested for laparoscopy and the surgeon is interested for laparoscopy. I'm giving an example, a case where there is a COPD, where the anesthesia could not be given, general anesthesia could not be given, the anesthetist refuses, and cardiac disease associated with it. I think these are the conditions where some alternative, either a vaginal or an abdominal, with the preference of the regional anesthesia is safer for that. You have to change the indications. Associated orthopedics problem. I have a couple of cases I have encountered, particularly associating these particular conditions with preclude anesthetic technique and preclude the position of the patient. I think I have seen a number of cases where we find orthopedically handicapped patients where constantly a poliomyelitis. I've seen a couple of cases requiring hysterectomy because of the pathology, but they're not able to flex, they're not able to extend the leg, they're not able to, they always remain in a flexed position for that. And some cases, they're ankylosed that they're not able to flex it at all. Totally, I think these are the cases where lithotomy patient is not possible. So what is the alternative? Think about it. Then, of course, the last is the preference of the patients. You cannot ignore, nowadays, the patients are so educated that you cannot ignore them. Preference of the patients about the route. They know everything about that. They know about the safety. They know about the morbidity, and therefore the participatory definition or participatory judgment has to be given in deciding the route. Then the physician profile. I have already told the general surgeons versus gynecologists for that. And I will always stick that my fellow gynecologists should be the surgeon and they should acquire a skill for development, skill development, training and everything, and acquire the skill, and therefore things will be all right for that. And apart from the skill, the psychosocial aspect has to be considered. The knowledge of the pathology of the pelvis should be there for that also, and no dogma in science. And therefore, the physician profile or surgeon's profile is very, very important for that. Well, I must quote here one thing, that nowadays I see that in Kiel, Germany, there's a big prominent laparoscopic center, and could say my hats off to this person who has really popularized and very, very emphasized on the gynecological laparoscopy, is considered the father of modern gynecological laparoscopy for that. And there in the center, they do not give a certification of a gynecological laparoscopy. They say the pelviscopic surgeon. Now a new term has come out in the pelviscopic surgeon. If a pelviscopic surgeon has come out, a different logy will come, pelvilogy. So a different subspecialty will evolve, where the gynecologist, conventional gynecologist will be obsolete. They cannot enter the pelvis. Only pelviscopic surgeons will be there. I see the future that only pelviscopic surgeons will take the gynecological things, will take the colonic part into them, and they will take the urogynecology part will be them. So there will be new emerging specialty of pelvilogy will be there for that also. I'm afraid, I'm scared of this, and therefore gynecologists, again wake up all of you to revive and acquire a skill and become a true gynecological surgeon rather than a pelviscopic surgeon. Pathology again. The uterine pathology is important. Uterine pathology will determine the route of the selecting the route. The pathology like the endometriosis, the adenomyosis, the myoma, whether it's indicated, if it's indicated for surgery, what is the size of the myoma, and that is important for that. And of course, before that, defining that it's a benign conditions, you must do assessment and exclude whether it's not a malignant. That's important. Uterine size and volume. Uterine size, say size up to about 12 weeks, 14 weeks, 16 weeks. This is just a clinical estimate for that. So here I will give more importance to the volume than the uterine size. And volume estimations is more now common with the employment of the sonography, and that is more important. Say a simple example I'm giving you. A case where there is a uterine size is 14 weeks. In another case, uterine size is 10 weeks. And 10 weeks, this is a cephalopedal dimensions. The cephalopodalic dimensions, it is there from that it is increasing the size. But we're ignoring the transverse diameters. We're ignoring the pathology. If a case of transverse diameter is increased, so instead of that, there is a broad ligament myoma, and uterus could be about 12 week size, but the broad ligament myoma occupying whole of the pelvis. It is much more difficult for that. So the pathology is important, as well as the size is important, and the volume is also important. The volume of the uterus is important. When you decide for a vaginal approach, the size, say 12 weeks, up till 12 weeks, it's within my range, I can do it for that. And of course, not only 12 weeks, the volume is important because the transverse diameters is also important for that. So therefore, 12 week size corresponding to about 300 grams or 280 grams of the volume. I think therefore, the volume is also important. Pathology again, dealing with the adenomyosis and dealing with the myoma, there is a difference. A myoma, bigger size myoma, you do an enucleation myomectomy and then remove it. But in the case of the adenomyosis, it takes a debulking procedures, and therefore the morcellation takes a long time and problem. So that is important. Adnexal pathology. Adnexal pathology in this particular case, you must be very clear to find out before attempting for surgery that it's benign. And therefore, we have got gadgets available like color Doppler, like tumor markers, you employ and then find out the adnexal pathology. At best, we can do, if it is not certain and the pathology, I think the adnexal pathology is suspicious is there, you go for an imprint frozen biopsy and do the procedure, and that will determine the route of hystrectomy for that. And of course, in suspected malignancies, the frozen biopsy can elucidate that, and you cannot go for the vaginal route. You cannot go for abdominal route. So these are the cases where still there is a place for abdominal route for that. And there is a multiple pathology where there is a multiple pathology in the lesions. You must decide whether you go for a laparoscopic or for an abdominal route for that. So overall decision-making factors when you're going for any route, say for example, a vagina. In the vaginal route, the size and shape of the vagina of uterus and uterus is important. Accessibility to the uterus is important. Extent of extrauterine disease is important. If the extrauterine disease extent is more, this is absolutely contraindicated. Need for concurrent procedure. It needs a surgical training and expertise. Average case volume. The case volume is more, you get more experience for that. Available hospital technologies, device and support. That is also essential. It's not that all supports are there with all gynecologists. So that means the supports is not there. The things laparoscopy is not there means you won't do. The available supports is doing for the best interest of the patient. And emergent and scheduled cases. And of course, the preference of the patient, which again I highlight that the decision-making preferences to be done. And if the preference is towards one procedure, and as a technical person, you find that that procedure carries more risk, you explain, participate in discussion that this is important, and he will be convinced, you will be convinced that yes, I will adopt to this particular procedure. So participatory discussion has to be done. Now coming to the then evidence. Every science must be evidence-based practice, and therefore, as regards hysterectomy, we have got two very prominent till today reviews. One is a Cochrane review, and another is a committee opinion ACOG in 2017. Cochrane review 2015, again modified in 2018. I will just put these two. Apart from it, there are many institutional evidence-based guidelines also, but these two are very, very prominent and very, very useful for that. In Cochrane review, there are 47 RCTs. VH, vaginal hysterectomy versus abdominal hysterectomy, there is one where 762 participants are there. Laparoscopic hysterectomy versus the abdominal hysterectomy, the RCT, 2,983 patients were there. In laparoscopic hysterectomy versus vaginal hysterectomy, 1,440 patients were there. And laparoscopic hysterectomy versus robotic hysterectomy, 152. And what is the review tells? The types of outcome in Cochrane review. One is a primary outcome, and second is a secondary outcome. Primary outcome, these are the pointers: return to normal activity, satisfaction and quality of life, intravisceral injuries like bladder, ureter, bowel, vascular injuries, major long-term complications like fistula, persisting abdominal pain, urinary dysfunction, bowel dysfunction, sexual dysfunction, and pelvic floor problem. And the secondary outcome are the operative time, other intra-op complications, sequelae bleeding in form of a substantial bleeding, needing transfusion, pelvic hematoma, and short-term outcomes and complications like length of hospital stay, infections, thromboembolism, post-op ileus, and wound adhesions. And last but not the least, the cost factor. These are the two outcomes for which, and the evidence-based dictum, they reached at a conclusion. Out of all these randomized controlled trial, with these extensive patients comparing the different procedures, the choice of routes, these are some of the evidence-based dictum which has come out. First, era of minimal invasive surgery. Defining minimal invasive surgery. Both the vaginal hysterectomy and laparoscopic hysterectomy are called minimal invasive surgery. My definition, I always say that open hysterectomy, conventional abdominal hysterectomy is an invasive hysterectomy. Minimal invasive procedure is laparoscopic hysterectomy. Non-invasive procedure is a vaginal hysterectomy. So, a big hole, abdominal, keyhole, laparoscopy, no hole surgery is vaginal. But as far as the evidence of Cochrane review concerned, they have categorized that era of minimal invasive surgery, vaginal and laparoscopy in MIS, and abdominal is not included the conventional. And first and foremost conclusion they have laid it. Vaginal hysterectomy is the first preferred route whenever feasible. Whenever feasible. Mind it, whenever feasible. Lap hysterectomy is the alternative if vaginal route is not possible, not feasible. Again, not feasible. Abdominal hysterectomy is to be considered when minimal invasive procedures are not possible. So abdominal hysterectomy has to be the last thing where vaginal and laparoscopy are not possible. And of course, robotic hysterectomy for benign disease, no evidence. This is the conclusion. Robotic hysterectomy is just a marketing hysterectomy. Robotic hysterectomy for benign conditions. It has some place in the malignancy. And of course, this is evidence-based for that. And of course, the last, opportunistic salpingectomy should be accomplished in all cases. This is the evidence that yes, all benign cases by doing hysterectomy, by whatever methods, by whatever routes, you do a salpingectomy that in concern with the prevention of development of ovarian malignancy, more of serious carcinomas for that. These are the dictum. And therefore, the maximizing benefits and minimizing risks. But the safety is first. Safety of the patient is the first and foremost. Result is the priority for that. And basing on that, whatever choice of routes you decide, you say that if abdominal is safe for the patient and the priority result is good, I will do an abdominal procedure. I have no dogma in any of the procedure for that. And therefore, I always say it is the need of the patient rather than the mood of the surgeon. And this is not applicable nowadays. I earnestly request you, introspect and find out at your own setup, analyzing all these criteria of the Cochrane review, all the pointers about this. But the two words like a feasibility and possibility I am not able to. These are $1,000,000 questions before me. Feasibility and possibility. Who will decide the feasible? I think it's an individual basis that you cannot uniformize the feasibility for that. One is not feasible for one patient or one person, is feasible for other person. And therefore, you are the best judge to decide. If I am the surgeon and this is the patient, it is feasible or not, that I will decide for that. And therefore, the individual judgment is important rather than a law or a common instruction given to everything for all kinds of patients. Now, this is a committee opinion of ACOG 2017, and see the comparison of different approaches to hysterectomy. Vaginal hysterectomy versus abdominal hysterectomy. Shorter duration of hospital stay, faster return to normal activity, better functional capacity, and increased pain assessment. No evidence of different satisfaction, intraoperative injury, and complications. No studies evaluating the cost. Vaginal hysterectomy versus laparoscopic hysterectomy. Shorter operating time, lower overall cost, more satisfied than LAVH. No difference between VH and TLH. No evidence or difference in return to normal activity, urinary tract injury, and complications for that. Laparoscopic hysterectomy versus abdominal. Faster return to normal activity, shorter duration or hospital stay, fewer wound or abdominal infections, longer operative time. It takes a long time. Higher rate of urinary tract injuries than abdominal. So laparoscopic hysterectomy, one of the great danger is the longer operative time and higher rate of urinary tract injuries. Of course, this is all related to the skill of the surgeon. More the skilled the surgeon, it will be done. These two things will not exist for that. Improved quality of life, no evidence of difference in satisfaction or major long-term complications. There's no difference and no evidence of difference in overall cost for that, because the hospital cost in their setup is much more for that. More the patient stays, more is the cost. Laparoscopic hysterectomy versus robot-assisted hysterectomy. No evidence of difference in any of the major outcomes. So therefore, no studies evaluating the cost. And therefore, this is again a question mark. The debate will continue when the things will change in future. So the changing trends now, what are the changing trends and changing techniques? The changing trends, non-surgical management, saving the uterus. I've already told, if the endometrium is defective, why you remove the myometrium, why you remove the cervix, and non-surgical management, saving the uterus. Even if myoma is a common indication, some medical management of myoma, medical management of endometriosis, these are all should be in a forefront. There is a lot of research going on where there can be a shift from surgical management to a medical management. And of course, if it is a medical, if it is a surgical management, it is a trend towards minimal invasive surgery. Everybody is trying to how to decline the rate of abdominal hysterectomy, declining rates of abdominal route rather than the minimal invasive surgical route. And out of the two minimal invasive routes, vaginal and laparoscopy, vaginal route is preferred when feasible. LAP approach is an alternate option. Remember this, the committee opinion and as well as the Cochrane review tells that the first is a vaginal option. If it is not feasible, then go for laparoscopy. If both are not possible, then you go for the abdominal approach for that. Supracervical hysterectomy, there is no place for that. I have a couple of experience of supracervical hysterectomy. Not in all cases. I do, particularly in a case where there is a couple of patients I've done with the mentally retarded, young, unmarried, mentally retarded, they're not able to maintain the menstrual hygiene, and 18 years, 20 years, and their parents are very, very keen for doing a hysterectomy. What else you do? A pin, whether do a vaginal hysterectomy, whether do there's no route. Professor Siris Seth has done a couple of cases with the vaginal route for that. But in my practice, I have not seen such type of cases where a speculum could be, where my one finger can be introduced into it. So in that particular case, I do a LAP approach, and therefore a supracervical hysterectomy, because in a younger age group, the chances of carcinoma cervix developing, you have given a immunization for that. And these are the cases where you can do a There is only indication which I find now, which a supracervical hysterectomy is the these type of patients where we can do the supracervical, and everything you remove by morcellator for that. Robotic hysterectomy, no evidence for that. Changing techniques. There are a lot of changing techniques power in surgery, has brought a new and light on the surgical procedure. Electrosurgical device, I have one focused attention, one episode I have dedicated to electrosurgical device, the vessel sealer, and more development of the vessel sealer, including the sear, the mechanical cutter. These are all improvement in the vessel sealer for that. And harmonic scalpel. Harmonic scalpel is again a power in surgery, which has really renovated the concept of minimally invasive surgery for that. Of course, in the laparoscopic procedure, the introduction of the 3D endovision. 3D is very important, because in some cases where they really need total laparoscopic hysterectomy, it's all cases do not require total laparoscopic hysterectomy. It is 90% of the cases can be dealt with vaginal route, where feasibility is there, where the rest 10%, when there is a pain, when there is a radiations, when there is an endometriosis, when there is a difficult surgery in a previous repeated surgery, I think the 3D endovision. The camera is important, the vision is important for the quality. 3D endovision. Viotome has been applied. I've done a couple of experiences with the viotome in the vaginal route, so that it becomes very easy. So you do a vaginal, apply the viotome and see the camera, and then find out in the detailed, deeper part for that. Uterine manipulator. Changing techniques, I think there is a lot of change in the uterine manipulator for that. The uterine manipulator, earlier we have manipulator which can manipulate from anterior to posterior. That's all, from front to back. That's what. So a manipulator could be from front to back, from side to side, and can twist and rotate in all directions, which can be safe for that. We have many designs for the uterine manipulator, and therefore it is the personal choice of all of you to use the uterine manipulator. In this connection, I must congratulate one of my favorite student, Dr. Sujit Behra, who has modified the different uterine manipulator. I've used it. I'm really delighted, and to say that is one of the best manipulator, very simple, and you are not afraid of that, and all purpose it can solve without any complications. And I congratulate my student. Once upon a time he was a student, now he is a teacher of mine. I think in this connection I must appreciate and take a name that yes, manipulator design. And all of you, I think, have a capability of devising some new techniques, new instruments for that in the changing era, and the changing techniques will be really, I'm seeing a very promising field for that. And you are one of the, I expect that you are one of the visionary, and everybody has a brain. You must put thoughts into it and find out and improve the techniques from time to time for that. Then the next is the changing techniques is the lateral pelvic wall and retroperitoneal dissection. It's very important in a case of endometriosis, where you have to be very safe from the ureter, very good extraperitoneally. It's not extra, it is a retroperitoneal dissection. It can be very well done with much more safety, and therefore it's very good for the type of case. So these are some of the changing techniques for that. Uterine artery at a ligation at its origin. Many people say that if you clamp it at the origin, you dissect it retroperitoneally and dissect it and clamp the uterine artery at the origin, then the bleeding will be less. Of course, I encourage this, but I don't promote this for all benign conditions, even without any adnexal pathology and without any lateral pathology, pelvic pathology. You dissect everything and the urethra, and then apply the uterine artery just for the sake of bleeding. I think it's a personal choice for that. So these are some of the changing techniques, and you must adopt which is best suited for the patient, not best suited for you. Then another technique, from lateral to midline in bladder dissection. Nowadays, we find more of post-cesarean cases needing hysterectomy for that. So post-cesarean cases is hysterectomy. The main problem arises with the adhesion of the bladder to the cervix, and there the lateral window. Again, I am reminded of the lateral window devised by the concept designed by Professor Sirisek in vaginal hysterectomy. You go a lateral window, laterally they are very free, and midline they are adherent for that. So therefore, in doing a vaginal hysterectomy, you used to go for a lateral approach and then come to the midline. And same thing also, the concept is applicable for abdominal, for the laparoscopic also. Even this procedure, see that while separating the bladder in the previous 1 or 2 or more cesarean sections, you go, the lateral wall is relatively free. And dissect that, find a cleavage on the right side and the left side, and it can be clearly delineated which is the central part which is adherent, and the safety of the bladder dissection will be much more. And it is applicable, and this technique is really important. Colpotomizer. The various colpotomizer has been devised but simple colpotomizer. Don't use some very elaborate colpotomizer for that. A tube, vaginal tube, ordinary vaginal tube can be used for that, a colpotomizer for that. Removal, that's a big challenge. Morcellation, the removal of the big uterus. Whenever they are doing a hysterectomy, the laparoscopic hysterectomy can be done in a very big uterus. But ultimately, the removal could be a problem and takes a longer time than the procedure itself. And the morcellation, risk of morcellation, debulking, in-bag morcellation in concept of the fear of malignancy. Of course, that is a theoretical possibility. You must investigate to preoperatively to find out a malignancy for that, rather than doing an in-bag morcellation for all cases. I don't accept the idea for that. And of course, the suturing. Initially, when laparoscopic hysterectomy was being done, the laparoscopic surgeon was doing that and suturing the vagina from below. Now, I think it's very clear. You can suture it from above, so that you can better suture it from above, because the vault fixation could be much more better in the angles. And initially, the vehicle was being used. Now, vault suture has made life of the gynecological surgeon, laparoscopic surgeon, much more easy. And vault fixation should be a primary. Otherwise, that will be vault prolapse for that. So these are some of the changing techniques and of the different varieties of hysterectomy. So, status of abdominal hysterectomy. All of you are diverted towards the minimal invasive. There is no controversy about it in the present era of minimal invasive surgery. But I say that the person who is doing all the three procedures know the merits and demerits of everything. So it should not be biased for that. And what is the status of abdominal hysterectomy? Let us have a glimpse of that. Whether the place of abdominal hysterectomy is there or not. Whether the declining abdominal hysterectomy, whether it will vanish or not. It is declining certainly, but it's still there. In my opinion, I will share that in very large uterus, the very large uterus is one of the indications for the abdominal hysterectomy. There is no doubt about it. One may be very efficient in doing that in a large abdominal hysterectomy, but you cannot say that all gynecologists will be doing in 30-32 week size uterus, particularly for that. So large uterus is certainly an abdominal hysterectomy from the present setup of the present era of minimal invasive surgery. Adnexal pathology, and more so when there is a suspicion of malignancy. Adnexal pathology for other regions, you can exclude malignancy and then do the job, laparoscopic hysterectomy in a case of the adenobacterioma or in ovarian cyst or in a hydrosalpinx or a tumors. But when there is a suspicion of malignancy, say for example, when the color Doppler is showing some suspicion of vascularity, say 125 is raised, and still you are not thinking that it could be pure malignancy. Now there is a place for frozen section. There is a place for imprint biopsy, and those cases will certainly change, and abdominal hysterectomy will be an option for that. So here there is an option for it. There is a choice of abdominal hysterectomy. Failed attempt of hysterectomy. I have a couple of cases. I think many cases I have received that. Previous repeated surgeries, laparoscopic surgery many times, the laparotomy and other surgeries for other appendicectomy and other things, and then planned for hysterectomy. And open and close. The surgeon in the periphery, they open and just see that everything is pasted, and they couldn't go for that and close. What these procedures you do, it patient will suffer. And these cases, I have a couple of cases which I don't remember the number, but quite good number of cases have failed attempt of hysterectomy. I think resort to the abdominal hysterectomy. Now, laparoscopy could be an option. In a very, very skilled surgeon, the laparoscopy can be done. It cannot say that it cannot be done. But the common acceptable route is abdominal in this case, in my opinion, for that. Associated diseases. If there is associated disease, couple of cases, I will just show some of the videos in that. Hernia, if there is a hernia associated with the pathology, you can do this pathology, you can tackle it with the laparoscopy or abdominal or vaginal route. But doing an abdominal, you can do it the same sitting, hernia repair and abdominal hysterectomy. If there is a scar endometriosis, couple of cases I have got it also. Scar endometriosis, majority of the scar endometriosis is limited to the parietal wall. But I have found in few cases in elderly women, completed family, the scar endometriosis is attached to the uterus, and there is a uterine pathology also. There is a endometriosis also. There is a combination. When you find an endometriosis in the pelvis as well as in the scar endometriosis, there is a choice. You must do it with that. No question of laparoscopy, no question of vaginal route for that also. as again associated conditions limiting positioning of patient, or the anesthesia part, I've already told, there you go for abdominal hysterectomy. Can be done under spinal anesthesia. Positioning, many cases I've done the patient operation abdominal hysterectomy with completely flexed hip, and whole life he is in the flexed hip, and I'm surprised, I feel pity on this type of patients for that. Conversion, again I say that conversion. Suppose you are doing a procedure of vaginal hysterectomy and then, or in a laparoscopic hysterectomy, at certain point of time you are not able to complete the procedure. So for completion, you have to convert it into laparotomy and do an abdominal hysterectomy. There is no ego for that. For the benefit of the patients and safety, conversion, you do it conversion. In these cases, need a conversion. And also, I admit that few of my patients, I have also converted into abdominal hysterectomy for that. And there is a place for abdominal hysterectomy. And of course, inadequate surgical skill of minimal invasive surgery. When he is not experienced with the minimal invasive, when he doesn't know the laparoscopic approach or doesn't know the vaginal approach, of course, abdominal hysterectomy has to be done, because then you are allowed to do abdominal hysterectomy. But as per science, now time is there to learn. You can better learn in a very short time vaginal and relatively little more time with the laparoscopic approach. Learn that to be up to date in the modern technology and science. Inadequate facilities, where the facilities are not there, where the gadgets are not there, you have to resort to the alternative methods. Now, of course, the patient preference I've already told for that. And therefore, there's a long list of indications of abdominal hysterectomy. And therefore, in the present status, in this century, I cannot say that abdominal hysterectomy has gone to the graveyard. It has not gone to the graveyard. Still, I believe that there is a place for abdominal hysterectomy in the present era of minimal invasive surgery, because I am a jack of all trades, master of none. And I can compare this. It's my feeling. It's my experience which I can share you. I have regularly, I am doing a vaginal hysterectomy non-descent. I am doing a laparoscopic hysterectomy, and I am doing an abdominal hysterectomy also. I can't say with all humility that all these three procedures I do practice, and basing on the need of the patient rather than on my mood, I require that. And decide on the need of the patient, which patient requires what. And I don't have an ego that I'm not able to do laparoscopic hysterectomy, resorting to only abdominal hysterectomy in this particular case. Now, the take-home message, it is important for the surgeon to select the operation that is best for the patient and not the one that is best for the surgeon. All you try, remember, all you try that can be removed vaginally, can be removed by the abdominal route or by lap hysterectomy. But the reverse is not true. There is a global reduction in the incidence of abdominal hysterectomy and a concomitant increase in lap hysterectomy and vaginal hysterectomy. There is a reduction. Only when vaginal hysterectomy is contraindicated, remember that. Harry Reach has also confined. The Harry Reach, who has founded the TLH as well as LIVH, first person, he told that when vaginal hysterectomy is possible, laparoscopic hysterectomy has to be condemned. It is the personal note of Harry Reach. And therefore, only when vaginal hysterectomy is contraindicated, lap hysterectomy should be considered. And when lap hysterectomy is not possible, abdominal hysterectomy has to be considered. It has not gone to the graveyard. Decision as to the route is based on patient's choice, expertise of the surgeon, and the setup available. These are the three tripods which is available for that. And adequate training is an essential component for the optimum result. That is applicable for all surgery. Now, coming to the last part, oophorectomy. Whether there is a lot of argument for that, a lot of people are confused at their own mood. They remove the ovary or keep the ovary. Oophorectomy, benign benign conditions of the uterus where hysterectomy is being performed. If the ovary is healthy, whether you remove or not. If the ovary is unhealthy, forget about it. There is a different indication. So, healthy ovary, where you remove it, where you keep it. These are the facts and fictions I have made it. That ovaries, after long years of dedicated service, is not able to retire gracefully. This is true. And in menopause, what happens? After retirement, the ovary is irritated and transmits this irritation to all the organs. And starting from the flaws to the urological problem, everything, sexual problem, everything will come out for that. And if you give a we give a compulsory retirement of chopping the ovaries, surgical removal, you imagine how angry will be the ovary in transmitting this anger to other organs for that. That discrimination in terms of dignity and respect exists between male and female gonads. Female gonads are sacrificed more often than male gonads. How many orchiectomy you are doing it for petty reasons? Then again, that female gynec surgeons chop off ovaries more frequently than their male counterpart. Forgive me for that. That ovarian cancer phobia is inherent amongst gynec surgeons. They all think that leftover ovary could be developing ovarian cancer. That it is very easy to put clamps lateral to ovaries during abdominal hysterectomy or laparoscopic hysterectomy, then put to clamps medial to ovaries during vaginal hysterectomy. Technically, it's much more easier. So, in vaginal hysterectomy, it is easier to put the clamp medial to the uterus, medial to the ovary, so that the ovary is retained. And during laparoscopy or laparotomy, it is easier to put a clamp in the infundibulum pelvic and dissect it rather than the medial to the ovary. And therefore, for a convenience, we do that for that. Then last, that unilateral oophorectomy reduces the future cancer risk by 50%. If you think that by removing one ovary, I will reduce the cancer incidence by 50%, that is not true. And therefore, if you are not, it is said that if you are not able to convince, at least confuse. I am not able to confuse you people, my favorite viewers. These are the facts, questions I am giving you. Ask yourself these questions and you will get the answer, whether you conserve it or you remove it. First question, at what age does the ovary ceases to function? You must know at what age the normal functions of the ovary lasts. Increase in normal age of menopause from 4th to 5th decade nowadays. Waning ovarian hormonal secretion during perimenopause. 23% of women show histologic evidence of ovulation even after age of 50 years. And we listen some of the cases of very, very postmenopausal ladies having pregnancy. Majority of hysterectomy for benign disorders are premenopausal. Only 3.8% are postmenopausal. Women with bilateral oophorectomy between 40 to 45 years may lose 10 or more years of normal ovarian function. So this is a very, very important data. If you remove the ovary at 40 to 45, they lose 10 or more years of normal ovarian function, which is beneficial for the woman's health. This is one important point. Keep it. Second question, do preserved ovaries continue to function normally after hysterectomy? You are doing a hysterectomy. Do the preserved ovaries continue to function? This is a target organ relationship. They say that when the uterus is removed, ovarian function declines. This is a theoretical possibilities for that. And this is a temporary thing, this can happen. And this has been reported and studied that is a temporary for few months or few years. Second, ovarian failure occurred up to 4 years earlier after hysterectomy compared with non-hysterectomized control group. This is a Sidland group has studied this. 11.6% of women who underwent hysterectomy had ovarian failure at the end of 4 years. Menopause doesn't increase in frequency following hysterectomy, but transient appearance of vasomotor flaws occur in approximately 40%. These are all transient phenomena. And transient reduction of blood flow and steroidogenesis after simple hysterectomy gives rise to this transient phenomena of manifesting the vasomotor flaws and other postmenopausal symptoms. Third question, can operative technique affect ovarian function? Knowledge of blood supply to the ovary you should know. Twisting, because there are two supplies, two directions. Twisting or stretching of infundibulum pelvic, are they going to have it? Clamps closer to the uterus is preferable than clamp lateral. Removal of the tube and will hamper the ovarian supply. No, it's not so. Whether peritonization and bursting suture around that next earlier while doing a hysterectomy, this was the routine procedure, so that the whole two ovaries are clumped to the two angles and the vault, and therefore nowadays it has not been practiced for that. Coagulation versus suturing, there is no difference for that. Are there significant health hazards when normal ovaries are removed from premenopausal women? If you remove it, what will be the health hazard? effect of sudden decline of estrogen, progesterone, and androgens. There is no doubt about it. Significant decrease of testosterone and its effect, that effect particularly resulting in the sexual function, long-term metabolic effects, osteoporosis, CAD, CVA, diabetes mellitus, and last but not the least, the psychological effect. Then this question, are there significant health hazards when ovaries are preserved in a premenopausal woman? What will be there if ovaries are preserved? There could be non-neoplastic problems and or cancer ovary. In the cancer ovary, only 0.1 to 18% variable results are there. Difficult to have evidence-based practice statistics for that. But it is starting from 0.1%. But non-neoplastic problems are more often. Benign cyst formation are more often. Residual ovarian syndrome, the pain because of the adnexal mass, severe pain, dyspareunia, generalized pelvic discomfort. And many of the cases, it is the hydrosalpinx rather than the ovarian elements for that. And therefore, nowadays, standard practice of opportunistic salpingectomy can eliminate the residual ovarian syndrome of hydrosalpinx as well as prevent ovarian malignancy in about 40% of the cases. How effective is hormone replacement? Now we say that you remove the ovaries and we have drugs for the hormone replacement. But there is a difference between pharmacologic versus physiologic, endogenous versus exogenous therapy. There are merits and risks, short-term and long-term. Choice of drugs is also a problem, and WHI study has clearly shown a lot of debate and controversies for that, whether regarding the long-term compliance and affordability. And therefore, more research is awaited for that. And therefore, last, how rational is age for oophorectomy? They say that age, discuss oophorectomy at 40, recommended removal after 45. What is the justification? Is there a justification of age with removal or conservation? It is arbitrary rather than rationality in cutoff limit in premenopause. So it's purely arbitrary. And now this has been, the modern trend is no age is defined for that. Consensus is postmenopausal. There is no doubt that in postmenopausal you can remove it. And in associated factors, these are the two factors removed. In a healthy ovary, postmenopausal, there is a consensus. And in associated factors like a family history of ovarian cancer, colon cancer, breast cancer, rectum cancer, this is all indicated. Even at the age of 35, completed family, you remove the ovary, healthy ovary for that. PJ syndrome and BRCA1 and BRCA2 positive. These are the only factors where you remove the ovary even if it is less than 40 years. And of course, the repeated surgery. If I've done, many people are prone to surgery. When a lot of, there are 3-4 surgeries already been done. These are the cases that are more for residual ovarian syndrome rather than for malignancy. So the consensus, organ preservation and age conservation regime is the essential theme of the millennium. Try to conserve the ovary as far as possible. Postmenopausal and risk factors for ovarian malignancy, like a family history of ovarian malignancy, BRCA1 and 2 positive, and PJ syndrome, and repeated surgery. You have a radicalistic attitude. And you don't compromise, remove the ovary. Age is only arbitrary, not rational. So forget about the age. How many cases of prolapse uterus in a postmenopausal in 50 years, 60 years, in a prolapse, you are removing the ovary? That you ask yourself. Adopting a proper surgical techniques, not to impair the supply, vascular supply, this is to be done. Unilateral oophorectomy, only psychological bias. There is no basis that you can reduce the incidence of carcinomas of ovary by 50%. HRT is mandatory while removing the ovaries, and lack of evidence-based statistics for that. And therefore, the consensus is that I have already convinced that these are the 3 main indications of removal of the ovary. Age is arbitrary. And therefore, the controversy, continuing debates and reaching at a consensus. And if you are convinced with this preaching, preach, practice, and profess. And remember, after these 3 P, PC Mahapatra for that. So the hysterectomy is the present scenario. The adversities on indicated surgery. From the beginning, I have told, be rational, be scientific in those cases where it is really indicated. Hysterectomy is really indicated. Ask yourself whether hysterectomy is really indicated for that. Recently, there was a survey in India there are three on-indicated intervention in medicine, where first on-indicated intervention is a cardiac intervention, second on-indicated intervention is a joint replacement, and third position we gynecologists have hysterectomy. We have in a third position. Earlier we were second, now we have gone to third. I think we will just go below and below on-indicated surgery. Roots. Coming to the roots again, I have told all the clauses of the roots, corroborating with the evidence, with the pathology, with the patient profile, with the surgeon's profile. It is the need of the patient rather than the mood of the surgeon. Role of general surgeons can be a helping hand. Gynecologist, I think, be awakened for that. Try to develop. You can judge which is there. There can be a good craftsmanship, but the judgment part, you gynecologist, because you know the pelvis, you know the pathology, you know the understanding of the psycho-social element of the women. Unethical practice, non-evidence procedure, commercialization of profession, absolutely condemned, to be condemned. Medico-legal scenario and altered doctor-patient relationship, again an adversities for that. So therefore, in the present era, where patients are literate, surgeons have become more complex, and society has become more adverse, I think you have to balance everything and proceed and do as far as scientific concern is possible, as far as rationality is possible for that. The most serious mistakes in the practice of gynecological surgery may be made by those who know only how. I caution, the most serious mistakes in the practice of gynecological surgery may be made by those who know how, but have not learned when and how, when and why. And therefore, how you should know, when you should know, and why you should know, not only how. Because there are innumerable operators in the world, but very few surgeons. Operators are many, surgeons are very few. And the purpose of this particularly E-Gurukul and the different workshops and updating your knowledge, scientific knowledge, is to convert operators to surgeons. Operators and surgeons are not same. And therefore, if at all you want to become a surgeon, I think just keep it in mind and all those which I've told, and introspect yourself and act accordingly. Because as a teacher for the last 40 years, I know that it takes 5 years to know how to do the surgery, and it takes 25 years to know what not to do the surgery. And that should be found out, and the message is that. And therefore, my teacher always tells, every surgery is easy, every surgery is difficult. It is the surgeon who makes the surgery easy or difficult. So the future is the organ conservation, saving the uterus concept. I think these also I'm aligning with that. Wherever it is not indicated, you keep the uterus. And there is a shift for medical management from surgical management. And it's true, it's good for the patient. Minimal invasive and non-invasive techniques has to be more encouraged. And therefore, there is a declining of the incidence of abdominal hysterectomy. Alternative to hysterectomy, focusing on medical management, focusing on conservative surgical management, like the endometrial ablation, like the other conservative procedures, these are to be adopted. And if at all surgery is to be done, it should be simplified technique. And the purpose of this E-Gurukul surgical skill transfer, the first and foremost priority is to share and make it more simple rather than a complex procedure for that. Telesurgery and advanced robotics could be in the future, and it has already come. Nanotechnology can really a game changer and change the situation. And I am dreaming after these fantasies, MAH, PAH, and CAH. I'm dreaming, this is a fantasy. This is the future thoughts I'm making it. MAH, enchanting a divine rhyme, and the uterus vanishes. Enchant a mantra, and hysterectomy uterus will be out for that. PAH, newer power sources and uterus shrinks. I had discussed with the different biomedical engineering company like Johnson and other. Instead of morcellator, why don't you find out a power which can generate more of energy? I will put 5 millimeter telescope and only one single port 3 millimeter and a big size uterus, 30 week size uterus, my uterus, put it at the level of the fundus, touch it and switch on the power. And within 5 minutes, the whole 30 week size uterus, the tissue will evaporate and shrink it to the P0 size. No cutting, no dissection, nothing will be there for that also. So this is newer power sources and power enhancing surgery, hysterectomy. Chip assisted hysterectomy. We entered in the era of chip technology. So chip, you apply chip so that hysterectomy can be done. And of course, here the place for artificial intelligence and there. When these will be achieved, gynecology will be in a new form and gynecologist in a new shape. I'm dreaming of that. I can't foresee them, but definitely in future, some of the fantasies may come out for that, because beginning of innovation is a fantasy for that, I believe. So, oh, Francis Bacon statement always, not to read, not to contradict and confute, not to believe and take it for granted, not to find and discourse, but to weigh and discourse, weigh and consider. Ladies and gentlemen, just giving these hints, you weigh and consider, and therefore that was the best thing in the world. Now this last part is the surgical dilemmas, situational analysis. I'll just land it with the situational analysis for that. Situation one, this is my own experiences and sharing the clinical dilemmas and surgical dilemmas for that. This is the first case, para 2, spontaneous vaginal delivery, all, both, 45 years, case of abnormal uterine bleeding, endometrium, E, no relevant abnormalities in history, sonography, bulky uterus, normal ovaries, PAP inflammatory, endometrium complex hyperplasia without atypia, hypertensive, obese. On examination, cervix is paras, first degree descent, no cystocele, rectocele, and uterus size not elicited. What is the plan? The ideal route choice in this particular case is vaginal hysterectomy. There is no doubt about it. Hysterectomy is necessary because there is a complex hyperplasia, family complete, 45 years, and hypertensive, obese. There is a place for hysterectomy, but the uterus is bulky and mobile, paras uterus, vaginal delivery is there, and therefore the accessibility is there and needs a vaginal hysterectomy. There's no doubt about it. So the techniques is anesthesia, regional, suture versus vessel filler, whichever you can use it, morcellation, no need, over and conservation, as per the situation indications, you can conserve this, and as far as possible, opportunistic salpingectomy has to be preferred. If the risk factors of ovarian malignancy is not there, then you have to remove, you have to conserve the ovaries if they're healthy. Situation 2, para 3, spontaneous vaginal delivery, 50 years, postmenopausal, pain abdomen. It's a pain abdomen and cervix is healthy, uterus bulky, restricted mobility, left fornix, there is a form lump, 10 centimeter diameter. Sonography, mixed echogenic lump, left ovary, and dimensions about 12 centimeter, 11 centimeter, 10 centimeter, and collar Doppler, mandatory postmenopausal. And the iota classification, you just imagine whether it's a which category of B or which category of M, then put it into it. No free fluid is there. One of the very good things. CA 125 is 60, but patient preference is lap hysterectomy. Whether you adopt lap hysterectomy in this particular case, I have still a suspicion that there could be some, because there is an increased vascularity on collar Doppler and CA 125 is raised in a postmenopausal. Patient in spite of patient preference. I will just convince with the patient and participate to discussion. And this particular case would be a clear ideal abdominal hysterectomy, because I want to do same sitting, a frozen section and imprint biopsy. So a frozen section and imprint biopsy, for that purpose, I will adopt this particular case for the abdominal hysterectomy. And these are all real life situations in my practice, which I've done that. And that's why I'm presenting. I don't know whether this is the correct or incorrect, whether you follow it or not. This is my the practice which by my experience and my thoughts I'm giving you. These are the patients' real life situations where I've managed like this, and the choice of route I've decided like this, based on this. Situation 3, para 2, spontaneous vaginal delivery, 40 years, AUB, L. History of Fothergill's repair. Sonography, intramural myoma, 7 centimeter anterior wall. Cervix is absolutely flushed with vagina, and uterus is 10 weeks, farm, mobile, furnace free. Cervix is not seen in that particular case. So what is the option? The ideal route. Ideal route could be laparoscopy is preferred. In this particular case, laparoscopy is preferred, but in skilled vaginal surgeon, this is not a contraindication for vaginal. You can go away with Fothergill's repair, previous Fothergill's repair. You can find out, and then just initially, the first step is up till the uterocervical, uterosacral, and the mechanoids. That is the point where there is a difficulty. After that, these things are easy for that. And I have a couple of cases which I've done also vaginal, but this particular case, I've done laparoscopy. because the vaginal route is possible, but in this case, nothing was visible. Situation 4, para 3, 2 spontaneous vaginal delivery, 1 LSCS, a 48 years, AUBL, sonography, uterus enlarged with 4 centimeters submucous myoma, family history of ovarian malignancy is there. Cervix is paras, first degree descent, cystocele moderate. There is a significant cystocele, uterus mid position on 8 weeks, and far mobile, furnace free. Endometrium is proliferative. I've evaluated everything, but the patient preference is lap hysterectomy. Again, lap hysterectomy, even if the patient preference, because I adopted a vaginal hysterectomy, because normally there is a history of ovarian malignancy, I have to remove the ovary, number 1. Therefore, BSO has to be done, whatever routes you have to be. And second, there is a vaginal delivery, 2 spontaneous vaginal delivery. There is a first degree descent and cystocele, significant cystocele, moderate. So I cannot do a lap hysterectomy. I have to deal with a complete surgery. I have to repair the anterior colporrhaphy, I have to that bladder and all that, because she has got a repeated UTI. So the best indication is that you do a vaginal hysterectomy with BSO and anterior colporrhaphy. This is indicated. Otherwise, this particular patient, if you have gone for a laparoscopic hysterectomy with BSO, then within few months, she will come with the vault prolapse for that. And the symptoms of urinary tract will be there for that. So remember, while examination, you should decide whether the pelvic relaxation is there, whether the component of cystocele, rectocele is there. Address all these in one particular procedure. Para 1 spontaneous vaginal delivery, 40 years with persisting pain abdomen. Absolutely pain abdomen persisting any time other than the during the menses. But along with that, she's having a menorrhagic cycle and dysmenorrhea is not relieved with medical management. Cervix is healthy, paras, uterus mid position, bulky, firm, mobile, furnace free, and sonography, adenomyosis, endometrium, simple cystic hyperplasia. So there, what is the decision? It is possible. The plan is laparoscopy. Vaginal is possible because vaginal, the uterus is not very big. It is an adenomyosis and it's a bulky uterus and she is a vaginal delivery as there. Cervix is healthy, paras, first degree descent, and a vaginal mobile uterus. So this could be easily done by vaginal route. But I will prefer laparoscopy in this because a persisting pain abdomen is there. So I will definitely put a laparoscopy and see what is there inside. And if everything is normal, then I can convert vaginal for that also. And I find uterus is adenomyosis enlarged, adnexa normal, no adhesion, no endometriosis, appendix normal, no other abdominal or pelvic pathology. Then I can say that for the persisting, if the predominant symptom is pain abdomen, I will definitely put a scope and find out for that. I have no dogma that I can do, I am laparovaginal route, I can do it for that. So this particular case will certainly have a broad, you have to have a broad mind to see for the patient as a whole, not particularly the uterus. So therefore, lap hysterectomy is preferable than vaginal hysterectomy. And here you can do a lap assessment and then convert the procedure into vaginal. There is no doubt about it. You look into it, exclude, then you can do the vaginal hysterectomy. This is one option, the best option. Or second option, you can do the lap hysterectomy whenever you're putting this. But my option is that this lap hysterectomy versus vaginal, I give priority to this vaginal hysterectomy. But if the predominant symptom is pain abdomen, even if the uterus is mobile, even if it can be done vaginally, I will definitely put a scope to see what is there inside. P2, first spontaneous vaginal delivery. Second is LSCS, 48 years, adenomyosis. History of ventral hernia repair, obese. Sonography, uterus enlarged with diffuse adenomyosis, 11 centimeter, 8 centimeter, 6 centimeter. Progressive dysmenorrhea, not relieved with medications. Patient preference is lap hysterectomy. What shall I do? Plan vaginal hysterectomy I will prefer. Because this particular case, even if adenomyosis, and they are presenting with only menorrhagic cycle and dysmenorrhea, and therefore there is an adenomyosis, it is a mobile uterus. My preference will be vaginal hysterectomy because the hernia repair, it is up to what suppose I put a scope also. There is a tendency, I expect that there could be adhesions inside the abdomen, which there could be injury for that. That is another risk. Adhesolysis, extensive adhesolysis I have to perform. Or again, the port hernia could be repeated for that, because these are prone for hernia, the abdominal muscles. So because of these reasons, I think the vaginal hysterectomy is preferred for that. So vaginal hysterectomy not a contraindication for previous cesarean section, because it could be there for that. P2, both LSCS, 46 years, AUBE, not responding to medical management. Sonography, bulky uterus, adnexia normal. Cervix healthy, nulliparous, uterus mid position, firm, mobile, furnix free. Patient preference is lap hysterectomy and plan lap hysterectomy versus vaginal hysterectomy. I imagine such patient has come, many of the patients, this patient has come from a very, very elite group, very educated group, and they have decided that they will go for lap hysterectomy. I told that, yes, I will go for vaginal hysterectomy. Then he said, no, sir, you are in the, I want a keyhole hysterectomy. Then I replied, I want no hole hysterectomy. I think which one you adopt? Then he became convinced. Then he became surprised, and I did this, and the next day patient was discharged. I think vaginal hysterectomy has a place for that. P2, spontaneous vaginal delivery, 45 years, multiple myoma uterus with menorrhagic cycle. Uterus is 12 weeks, firm, irregular, mobile, furnix is free. Ideal route, vaginal hysterectomy, 12 weeks size, 45 years, para 2, mobile uterus, 12 weeks. You say, as the skill of the surgeon increases, he can do up to 18, 20, 28 weeks also. There is no doubt about it. But minimum is that 12 weeks or 280 grams is common for all gynecologists concerned. And particularly looking at your level of all gynecologists, I will advise that 12 weeks, this particular case, better preference will be vaginal hysterectomy. And need for debulking. You have to debulk it, because at 12 weeks, multiple myoma, you're debulking it. P2, spontaneous vaginal delivery, 42 years, dysmenorrhea, menorrhagic cycle, sonography, bulky uterus, ovary normal, cervix paras, healthy, PV, uterus bulky, firm, mobile, furnix free. Again, plan for vaginal hysterectomy. This could be done very easily by a common gynecologist for that. And there, I started doing that because the indications wise, I didn't find anything, but I found a difficulty on the way. I decided for vaginal hysterectomy, but posterior pouch find a difficult entry. Undiagnosed pelvic endometriosis in the posterior pouch. Rectosigmoid completely adherent to posterior surface of the uterus. And believing that it's a bulky uterus, spontaneous vaginal delivery, and mobile uterus by clinical examination. Then what next? Undiagnosed situation, what next? Keep going close to uterus and everything will be possible. And surgery was possible. Even if you find that undiagnosed entity, you go closer to the uterus. That's the fundamental principle. Any route you go, closer to the uterus. And vaginal more so. If you're closer to the uterus, posteriorly, rectum and rectosigmoid is safe. If you're closer to the uterus, anteriorly, bladder is safe. If you go laterally to the uterus, ureter is safe. What else you require for that? So therefore, undiagnosed, many cases I have faced undiagnosed endometriosis, which I have not done, converted into laparoscopy. I've really done that with the vaginal procedure. Even endometriosis, ovaries and all that, that can be delivered by vaginal route. If their ovary is fixed to the lateral pelvic wall or the chocolate cyst, that can be removed also by vaginal route. P3, 2 vaginal delivery, 1 LSCS, 50 years, multiple myoma uterus. Uterus is 14 weeks, irregular, restricted mobility, furnix free. Planned vaginal hysterectomy. Again, after uterine artery sealing, I planned it. I'm taking more adventures. The size is more, 14 weeks with 1 cesarean section, and uterus is mobile, and that's why uterus is restricted mobility. So with the risk, I've taken vaginal hysterectomy. So many people have tried. They trial vaginal hysterectomy, always trial labor, trial forceps, trial vaginal hysterectomy. But I will say that this case I planned for vaginal hysterectomy. After uterine artery sealing and myomectomy, I found a difficulties encountered. Then what I'll do? Planned a conversion. Then we put a scope and complete the procedure, either a laparoscopic hysterectomy or a laparotomy. There is no ego in that. This is one of the cases where you do a conversion for that. Now, this is a case where para 3, 2 vaginal delivery, 1 LSCS, 50 years, multiple myoma uterus. And on examination, the same thing. So no 14 weeks, irregular, restricted mobility. So again, I'm telling you, find a difficulty after a certain procedure. and planned conversion, lap approach, whether abdominal. Anything can be done, and no dogma and no ego in science. 18 years, unmarried, mentally retarded. History of hip surgery, ankylosis both hip, menorrhagic cycle with dysmenorrhea. Sonography, bulky uterus, endometrial thickness 8 millimeter, normal ovaries. Patient preference is lap hysterectomy. They are conversant, they are educated girl of 18, educated parents of 18 years, mentally retarded. The parents wanted is lap hysterectomy. But ideal route here is the positioning. I can't do the position. And therefore, this particular case, I did an abdominal hysterectomy, and that I will definitely devote for that. So intra position is an important factor for consideration. 38 years, para 2, both spontaneous vaginal delivery, AUBL, myoma, known COPD and cardiomyopathy, both on examination, cervix healthy, paras, 12 weeks, firm, mobile, left fornix cystic lump 6 centimeters. And sonography, posterior wall myoma 8 centimeter, with left ovarian serous cyst 8 centimeter. Collar Doppler is normal. And this particular case, what shall I do? Whether vaginal or abdominal or laparoscopy? I think certainly for the sake of anesthesia, for the sake of the comorbid condition, vaginal hysterectomy is preferred. You can do an abdominal, but spinal regional anesthesia is much more safer for that. In regional anesthesia, you can do the laparoscopic procedure, but general is the recommended procedure. But in a case when the cardiomyopathy and COPD are definite contraindication for pneumoperitoneum. So therefore, vaginal hysterectomy is a preferred thing. So lap hysterectomy is not suitable for anesthetic point of view. Situation 3, para 1, LSC has 48 years, pain abdomen since last 1 month, menorrhagic cycle. For abdomen, suprapubic lump, 14 weeks. PV uterus enlarged, irregular, 14 to 16 weeks for restricted mobility. Sonographic evidence of adenomyotic uterus with left adnexal hypoechoic mass with increased vascularity. Planned for laparotomy, as I have already told, and imprint biopsy. See the surgery for that. Laparotomy done, and right uterus is enlarged. Right ovarian tube normal, left ovarian tube buried to the posterior surface of the uterus, and degenerated soft pedunculated mass arising from the fundus. The other ovaries and tubes are normal. You see, this is one side of the ovarian tube which is normal, and there is a degenerated myoma arising from the fundus and is a pedunculated mass. And therefore, these are the cases where it seems pathological, and therefore, this particular case, I wanted to do an imprint biopsy, send the specimen for imprint biopsy, did a total abdominal hysterectomy with bilateral salpingo-oophorectomy, send it for the imprint biopsy of Fogen section, and report came within 15 minutes, and it came out to be degenerated myoma, and my surgery is complete. And I did not go for pelvic lymphadenectomy or some omentectomy and other thing as per the malignancy for that. So therefore, these are the cases where laparoscopy is also not indicated. Vaginal is not also suitable for this particular case. So therefore, these are some of the indications where is done. And all cases you see that all previously suturing has to be done. Now we are all employing with the vessel sealer, and these are the cases of vessel sealer. We use it, and this is a case where 2009 videos, and nowadays I've revised many of the improvised instruments where the rapidity is much more better, and the safety is much more better. The lateral spread is least. Now the newer design of vessel sealer can seal it and cut it either with the shear, with the same force with the current, or the mechanical cutter with absolutely very good vessel sealing efficiency for that. And therefore, these are the cases where the open hysterectomy, there is a place for abdominal hysterectomy for that. These are all how you see the infundibular pelvic, which is there for that, and infundibular pelvic, I'm applying that, removing both the ovaries, and then and then you just remove these and send it for the imprint biopsy and protein section, and then see that these things could be more scientifically and rationally approached for that. And you can do a suture, you do a vessel sealer, but vessel sealer is having our life much more safer, and the patient's life also, because the post-operative pain is very, very less with this approach for that. And the whole thing, the uterine also can be tackled with that. And now you see the uterus, the bladder. This was the case of bladder, how you remove this bladder, because they post cesarean and remove the bladder by seizure only. So dissection always with seizure. Earlier, people are using the blunt, the sponge and holder for that sponge. But instead of that, the seizure dissection is much more. And again, I say, start from lateral to medial. And therefore, in the case of previous cesarean, the midline, the bladder is adherent completely to the cervix, and therefore go from lateral to medial, go through the proper cleavage, and things will be all. I believe in the preventive surgeries, all steps. So these are some of the techniques which everybody should remind, and go slow and identify the structure. You need not do a ureteric dissection in all cases. People say that ureteric dissection is only done in a case where there is a mass. You have a retroperitoneal dissection in the lateral wall, and when there is a mass incorporated to the lateral pelvic wall and the ureter and the posterior aspect, rectosigmoid, those are the cases only I will recommend for the extraperitoneal approach. But these are all the cases where it is not indicated, but we very, very meticulous on the hemorrhage, on the sealing of the vessels for that. These are very good vessel sealers available, and everything you can do it. Only the last step, by opening the vault, you can close it. At the fixation of the vault is necessary. In the two angles, it is required to have a suture, but the rest of the cases, no suturing is required for that. And in fact, now with the evolving technology of the new vessel sealer like shear or improved design of this, with the best the IQ machines and available are that, and newer designs of the cutter is available for that, along with the sealing. There's a cutter available, and these particular cases are much more easier to deal with, and the whole thing can be delivered. Whole thing can be done without a suture and sutureless, till the last part where you just open it, the vault, and close it. That suture is necessary for that. And see that by using this, the total amount of bleeding will be less also, and then you can complete the procedure. This is the uterosacral mecanrod, which is to be dissected, and the bladder is already gone, and the same procedure you can adopt for that. And once the angle is open, you catch hold of that and open this with the again a vessel sealer, so that the bleeding from the vaginal edge will not be there, and you are really very secured about the hemorrhage for that. So this procedure is very, very good for that. In all abdominal hysterectomy, I employ that, and in all malignancy also, I employ that vessel sealer, so that the sutureless device, suture has a many, many great advantages for that, and it makes life easy. Now the vault is open, you have to open the vault, and with the same vessel sealer. Nowadays the cutter is available. At that time the cutter was not there, only sealing and cutting with the scissor. Now the cutter is available, and things become much more easier now, and you can automatically cut it with the vessel sealer, with the cutter available, either the mechanical cutter, or you can employ the electric cutter like shear, where the same current can seal it. And the Indian companies like Alan and PB are very good. And Alan instrument, I like it that this is very good instrument for cheaper and good instrument for vessel sealing. The sealing is good and the cutting good, and you need not again have to employ scissor for that, so that the unnecessary time waste is not there, and you can complete the procedure with a less timing for that. So this is how you remove the uterus and then send it for the biopsy. And then after the biopsy comes within 15 minutes, you can do the rest of the procedure if it becomes malignant. Otherwise, you rest assured that if this particular case comes out as a degenerated myoma, as in this particular case, the question of extensive surgery, radical surgery doesn't arise for that. So this completes the procedure. Only thing is that the vaginal vault has to be sutured on both ends, and see This is how one of the techniques I've shown you for this abdominal hysterectomy. So undiagnosed mass with vascularity, need for laparotomy and imprint biopsy is necessary. So definitely place for abdominal hysterectomy. Para 2, spontaneous vaginal delivery, pain abdomen with perception of lump abdomen. There is a firm lump of 32 weeks, restricted mobility, sonography evidence of multiple myoma uterus with chocolate cyst ovary left, planned for abdominal hysterectomy. This particular case, a large size of the uterus, 32 weeks. I am not that experienced to handle this particular case. I felt that it is beyond my limit to go for a laparoscopic hysterectomy in this particular case when I find that 32 week size uterus with the with endometriosis. I find that this is the best thing I could do, that taking the risk of the patient, I thought I will do an abdominal, and this is a procedure where the compromising the incision. Normally, people will have a tendency to give for a longitudinal incision, but longitudinal incision has its own demerits for that, and therefore I gave a transverse incision, again a phalangeal incision, and did the procedure with that. And this could be possible. Of course, the delivery is a little gymnastics. We have to do that, but compromising with that, the advantage of the vaginal, the advantage of phalangeal incision, the transverse incision, rather than the abdominal midline longitudinal incision, which I've already showed also in the incision in the episode. One of the episode was dealt with as an incision. So then there is a little difficulty because the space is less, size is more, 32 weeks. But I think with the expertise, and you all of you can do it, this procedure by practice. It's a surgeon's inconvenience is directly related to the convenience of the patient. And therefore, I believe in that concept, even if I find a little difficulty about the space, but things could be done. If things are compromised and the quality of the surgery will be less, then I will change the. Otherwise, I will continue to have it basing on the convenience of the patient. So I find now the techniques is that the forgotten myoma screw. Myoma screw is a very good equipment now for this type of the uterus. A large uterus can be delivered very well. And if there is a uniform enlargement, I still use the vacuum also. Vacuum cup can be used. But here it is just so large and so multinodular, multiple myoma, it is not possible to apply on a particular seeing for that. A good assistant with the classical gymnastics, I could remove this myoma and see the myoma, 32 weeks myoma, multiple myoma, and not only myoma, there is an endometriosis obliterating the pouch of Douglas for that. As we go more and more of the myoma comes in view, and there is a difficulty because there is a posteriorly, there is a rectosigmoid is other end, and you see the rectosigmoid which is other end for that. But it is possible to do that with them. But therefore, these are the cases, the choice of the route is abdominal. It cannot be a laparoscopic. It cannot be a vaginal also. Even if an expert vaginal surgeons are there, I don't recommend that this particular case can be done by vaginal route. Laparoscopy may be that exceptional endoscopic surgeon can attempt and dare to do that. And it is possible. The size is not a factor in laparoscopy. Big size uterus can be done by laparoscopic approach. But the main problem occurs with the retrieval. The removal of the tissues in a big size is really a headache and a problem because it takes not only a long time, but a high level of dexterity is required for that. So because the endometriotic lesions are there in the posterior surface, it is I'm facing a difficulty in that. But at last, I could do that and deliver it. And gradually, you just ligate or apply the vessel sealer on the two sides on the infundular pelvic, or if you want to remove if you want to conjure the ovary, if at all they are healthy, that's all right. But here another thing, in the left chocolate cyst, there is a left chocolate cyst which is obliterating for that and is adherent for that. And therefore, you have to go to the proper cleavage and bilateral sulping over your lysis, you do it first and find out the cleavage. Then the rectosigmoid, you have to separate it in the right cleavage so that you don't go for a rectosigmoid injury, and then do the procedure as usual in the complete procedure with the special precaution on the rectosigmoid. You go very gently, you must go and tackle the procedure so that whole procedures can be done with that same thing, with the meticulous technology for that. But the main thing is that you must have a very, very meticulous over the safety area. And this is another ovary on the other side, and the tube which is fixed to the ovarian fossa and the posterior surface of the uterus and the rectosigmoid. The other side, the right side. So it is almost both the ovaries and tubes. We just freed it. Then the rectosigmoid, we freed it, and then we can start the procedure with the same thing, right round ligament, then infundibulopelvic ligament, and the uterine, and then subsequently the rest of the things. The uterine also can be handled with that. Now, only one thing, one technique I will advise you here, that in such a large uterus, you go and tackle, and after the uterine vessels, I think the problem of entry into that cervix in the pelvis, because of the space, limitation of the space, you just remove it, do a subtotal hysterectomy, and the stump, you catch hold of that and then approach for that. It's not the total subtotal hysterectomy in the final thing, but in the surgical procedure, you just remove the mass so that you can get a good space in between, and then you catch hold of the stump and then go and complete and remove the stump in the next phase for that. This is another method in large uterus. I always advise that you do this procedure for that. So this is a infundibulopelvic. The ovary is only fixed to that part, and the other side, the ovaries, there is a chocolate cyst. Both you remove it, and the same rest of the procedure as in the first case, the same procedure I did it, and close the vault with again the vault fixation for that. So the message, it's possible with the transverse incision, abdominal approach, the preferred route, lap approach with very, very skilled hands, and it's a prone for complications also with skinned hands. And therefore, the recommendation in this particular case will be abdominal, because the removal of the uterus is also a real problem, and safety is the first thing. There's another case, P2, both LSES, AUBA, adenomyosis with incisional hernia, and their ideal route. What would be the ideal route? You see that this is a case of incisional hernia with adenomyosis needing hysterectomy. I could have done the hysterectomy, hernia, keep it aside with the second sitting, doing that in either vaginal or abdominal with the existing situation. But as because the hernia is there, I decided to do it with that same sitting. Only thing is that the bladder was densely adherent here because the previous cesarean section. Otherwise, the uterus is mobile and it's not very big. It's about 10-12 centimeter. These are the cases where abdominal has to be done. I decided because I had to go for a hernia repair. An anatomical hernia repair, I always pay for after doing a hysterectomy, and you just dissect it. The dissection is very important. Here we find that because of the previous cesarean, it was densely adherent for that. And be careful about the bleeding, be careful about the bladder. And here you go gently from above and start from the lateral part. This is important. Again, I have to reiterate that the lateral approach is to be done first, then the midline approach. And midline approach, you go more towards the cervix so that the bladder, you don't injure it further. And if at all there is an injury, you can repair it, but at least try to have a preventive surgery for that, so that the bladder is not injured for that. And therefore, the same procedure, we do it with that vessel sealer. You can do it with the sutures also, and from the beginning till last. And remember, even if you are using the vessel sealer or suture, always advise that go closer to the uterus. Closer to the uterus is always best for that, and closer to the uterus is always best. Okay. And therefore, that because of the two indications, you see now that the vault is kept open. Vault is now suture, vault is now coagulated, and so that the bleeding will be less. This is the advantage of using the vessel sealer for that. And the two angles are held on either side with the midline so that you can suture it to close it, and vault fixation can be done with that. And this is a final thing, that the uterus is out. And after that, the vault closure, technique of vault closure, I will just show you how you close the vault. On the angle on both sides, you just close the vault and then again reinforce the suture. This is the vault which I'm closing with that angle of the vault. And this initially I've led it with that to see that the angle of the vault is not inverted, it is everted. so that it don't take a figure of 8 suture, which previously the people are using it. I'm against the figure of 8. I'm using the mattress. Again, second reinforcing suture, I'm putting it. And this suture, I will take a bite from the uterosacral and again fix it to that. And so that the main purpose of the fixation to the vault is there. One on this side, one on the other side, and then the middle part, I just keep it, either you can keep it open or you can have one suture, transfer suture in the midline, so that the middle, so that the things will be okay for that. And then after the procedure, you start with the one hernia repair, and hernia repair can be done by you. I think the gynecologist can do the hernia repair for that. This is how the small oozing from the bladder muscle which is there. So I'm just ligating this muscle. There is not a bladder injury is not there, but still I gave 1 or 2 sutures for that to close this. And again, now the second procedure started with the hernia repair. I'm just showing that how the hernia repair needs a meticulous dissection of the tissues. It is not that you just at random close it. Because the mesh is there, you can put it for that. So anatomical repair and reinforcement with the mesh gives a much more better result for that. And give a priority to the anatomical repair. Just dissect the muscle and the rectus sheath, and the redundant thing you can excise for that, and you must oppose for that. And layer method, you can close it, the peritoneum as well as the muscle, and then the rectus sheath could be done for that. Now the whole of the rectus muscle on either side, there's a divarication earlier. Now we can dissect it, and then you can do an excision, redundant portion, the fibrous portion, you can excise the hernial sac so that you can close it in the right direction for that. These are all the redundant fibrous tissues in the rectus sheath and the peritoneum, which can just excise for that. And then after that, a layer closure has to be done, and the peritoneum. Then we go for a rectus sheath mobilization. This is the sheath which can put it, and all the directions, interior, posterior, and lateral on the right and left, you can dissect it and then put it for that. So that I can say that all gynecological surgeon can do the hernia repair also, initial hernia repair. They blame that, surgeons blame that you create the hernia. We don't create, we create the hernia, we treat it also, that's all. You remember that you take measures not to have a hernia. That's a primary prevention for that. But even if I find that incisional hernia, I think it can be better dealt with by the gynecologist also, the same thing. But I always prefer the layer method for that. So after the dissection, complete dissection on either side, these are the peritoneum, which I'm giving a running suture, and then then the muscle, the 2 muscles which is there in a divarication, which has to be opposed in the center in between, and that gives the additional strength for that. Then the rectus sheath, I give that. And in addition, in the last, you can give a reinforce with a mesh, and that will serve the purpose for that. This is the same thing. And earlier we were using the proline suture for that. But again, I say that if you're doing a good dissection in this particular case, even vicryl can be a better option for that. So vicryl can be a good suture as par with the proline, which can be offered for that. And after the closure of this rectus sheath, you can go again, either some cases when you find that if it is not opposed, they put a dip. I always see that anatomical closure should be done, and along with that anatomical closure, you can put a mesh. I think after closing this the rectus sheath, this is the mesh which has been given, and then this reinforcing of the mesh will have a better long-term prognosis, and long-term results for that is much more better. But even without mesh also, anatomical repair, I've done it quite often, and it is much better for that. This is para 1 abortion 2 LSCS 40 years with AUB-A adenomyosis with pelvic endometriosis, with scar endometriosis. And therefore, if there is a scar endometriosis with pelvic endometriosis on ultrasound and a parietal lesion, this is the case. There is no doubt that in which row to laparoscopy has a place for that. And laparotomy has to be done with a decision of excision of scar endometric nodule, and the parietal wall is about 10 centimeter is there, and wide excision of the peritoneum, the scar endometric nodule is essential for prevention of the future recurrence, and therefore you go to that. Remember, I've done a couple of quite a good number of cases of scar endometriosis excision and varieties of scar endometriosis, and I've shown you in the endometriosis episode. But majority of the scar endometriosis, they are limited in the parietal wall, and the uterus and ovary is normal. But in some cases like this, there was an element of pathology in the pelvis in terms of the adenomyosis or in terms of the chocolate cyst, along with the scar endometriosis in the parietal region. And majority of this scar is up to limited up to the rectus sheath and up maximum up to muscle, not beyond that. But this is a case where you find I dissected from all around and found that this is attached to the fundus of the uterus, and fundus is fixed directly to the scar endometriosis. So I dissected that and excision, particularly the endometriosis in totally, and wide excision is necessary, as you see in this particular case, how wide I have dissected this. And then gradually you go and approach the fundus. When I fundus, I find that this is attached there. Then in the same sitting, I did this abdominal hysterectomy with excision of the scar endometriosis in the same sitting. And this is possible. And this is a way which I am showing you the videos that this is a common condition which all gynecologists, average gynecologists can able to do it for that, and that is possible. A good meticulous hemostasis is necessary. The electrosurgical, the monopolar current is very, very important for that, for not only for hemostasis, but for dissection. This is very, very important because this is aids to the bleeding, helps in bleeding to a considerable extent for that, and goes to the proper cleavage so that we can get a good piece of surgery for that. So the meaning thereby that when there is a scar associated lesion in the abdominal parietal wall, I think you have to resort to abdominal route, and in the same abdominal route, you see the whole thing, both the things can be tackled in the same sitting for that. And therefore, this is a big endometrial nodule which sonography can underestimate, but in reality, you have to go wide excision, otherwise the recurrence will be there for that. And after that, opening all these, you can enter into the peritoneal cavity and then do the hysterectomy in the same sitting for that. And then many of the cases you find the same adhesions as in a case of pelvic endometriosis. You must be very, very meticulous in not injuring the rectosigmoid and the ureter in particular. So necessary skills has to be developed, the techniques has to be learned, and by virtue of experience, you can do a good job with that procedure for that. Now, 45 years nulliparity with previous history of lap surgery twice for pelvic endometriosis. Not conceived, persistent pain with diffuse adenomyosis and myoma, menorrhagic cycle and dysmenorrhea, sonographic evidence of diffuse endometriosis with chocolate cyst, failed attempt. Somebody has attempted it and couldn't complete the procedure, and therefore planned for re-exploration for this particular thing. So this is a case of pelvic endometriosis with myoma and adenomyosis, failed attempt at laparotomy, and the uterus is 16-week size, and this is the sonographic view. And on opening, I find that the endometriosis is there, but it is also myoma which is incorporated along with the adenomyosis. Many of the cases do behave like this, and you go in the same direction. And these cases which I find that I always give a space, say 2 months, go leave immediately, don't do it, leave it for 2 months, and after 2 months, I think minimum period, you just do a re-exploration for that. You don't subject the case immediately for surgery, and that will be more hazardous for that. So that is the main thing I want to express before you, that this is possible. You can take help of surgeon's hand and surgeon's help for that. In some cases, these are the cases which you anticipate the problem of the adhesion of the bowel for that. You can take help of the surgeon, but majority of the cases you can do it. And in my experience, and I have seen that these are, if you are meticulous enough in just rectosigmoid, and if there is adhesions to the bowel, you can from the beginning very cautious about the preventive aspect. I think things are very good for that. So these are the cases where the abdominal hysterectomy is mandatory, and abdominal hysterectomy, there is no option there. You cannot do it by the vaginal route. You cannot do it by laparoscopy also. So These are the cases where a very skilled laparoscopic surgeon can do it. I don't deny that. But again, you have to do an extra retroperitoneal dissection. You can go for with the 3D laparoscopy. It will take a long time, and experienced surgeons can do it also. I don't say that these are absolutely contraindicated. For the average gynecologist, I think these are the cases you don't take a risk and do the procedure. And you see, initially, because of the previous surgeries, repeated surgery, there is a lot of adhesions, but very meticulously you must separate through the proper cleavage line, and then it is possible to do the procedure. There is not absolutely a contraindication for that. So these quite often we get some such cases like that, and I really when our students have referred this to us and that level, I also feel that yes, I must give a justice, and I should do the procedure in an uncomplicated manner. And we are very stressful when we get this type of cases till the patient is discharged. And I think this is with the average knowledge, with the average gynecologist can tackle this procedure. And always the preventive surgery. Try to do it in a preventive manner so that you don't injure. So therefore, I was slowly going, and even entering to the pelvis, entering to the peritoneum is difficult. And here you are liable to injure the gut, which is adherent for that, is expected adhesions for that. So very, very gentle you must go it so that you can open the abdomen very well. Then this myoma screw again is absolutely everything is adherent, only the fundus is visible, and POD obliterated, rectosigmoid adherent, adnexa, and all are not seen in that. And gradually in the fundus with the myoma screw, you can deliver that, particularly the myoma with the adenomyoma, and because of the adhesion in the pouch of Douglas, like in the previous case, this is very difficult. This is a fundal myoma. This adenomyosis is there, but a fundal myoma is there here along with the adenomyoma. But these are all adhesions all around in the lateral part, in the posterior part mainly, not in the anteriorly, but posterior POD is obliterated, and you must free the adhesions first with the omentum, and the gut could be adherent for that. Be very gentle, not apply the current in the gut, but if the omentum is there, that is all right for that. But these are all fused. These are all pasted. The rectosigmoid is not the separated. These are all the uterosacral, which is the posterior part, is absolutely fused with that. And these are all posteriorly. The adenomyosis uterus can be seen. Only the myoma in the fundus appears to be a myoma, but ultimately on cut section, it came out to be adenomyosis for that. So these are blunt dissection can better deal with that. Blunt dissection and very gentle dissection will be there. Don't apply the current. And now you can see the endometriotic, dense endometriotic cyst, which is adherent for that. Nothing is identified, but go very, very slow and meticulous dissection can really serve the purpose and really benefit you for that. And you see the rectosigmoid, how it is there, fixed with that. Both the necks are fixed with that. And this is the ovary, which is also fixed. And the ovarian tube, just by blunt dissection by the finger, I lifted it out, the ovaries and tubes. But this ovary, the other side ovary, is absolutely fixed with that. So only problem is that in the rectosigmoid and the pelvic endometriosis, this is very liable to develop the injury to the gut, colonic injury and rectosigmoid injury. So if you are very, very meticulous, I think nothing will happen. And go always closer to the uterus, identifying the structures very well. And then, so this dissection is important, and then start the procedure of removal, apply the clamp, and gradually, if you apply clamp, or vessel sealer, and go from the first pedicle and then go downwards, things will be easy, and you can complete the procedure uneventfully for that. And quite often we see such type of cases where the 3D laparoscopic approach can be, and the extraperitoneal approach, this particular case will certainly need an extraperitoneal approach for that. Way back in 2007, this is the video which I'm showing you. Now the newer instruments are there, newer hand instruments are there with the vessel sealer and the cutter. I'm using that cutter also. This is a myoma associated with that, additional myoma, 2 myomas there in the lateral aspect, along with the adenomyoma for that. So the new generation of the vessel sealer, safety is there, lateral spread is less, the local rise of temperature is less, and main thing is that your astute judgment of dissection in a right plane of cleavage is important for that. So this is all that can be done with that, and it is possible. 40 years unmarried, case of poliomyelitis with ankylosis of both hip joints, failed medical management, menorrhagic cycle with dysmenorrhea, multiple myoma uterus. This is a lady unmarried, is a teacher. I remember poliomyelitis, and from the childhood is poliomyelitis and ankylosis of both hip joints. He was in a different posture all around, all along the day and night. He was in a always in a flexed position for that, and both the hips are flexed to the abdomen, and uterus was 16 weeks, and therefore I planned for abdominal hysterectomy for that. So this is a case where incision is again a foreign still. It's a myoma uterus of 16 weeks, but luckily there is no adenomyosis for that. But the position itself is prohibiting me from other procedures. So here, myoma of 16 week size, but no adhesion. It could be very well lift up and then do the procedure or the rest of the procedure with that. So there is no adhesion and absolutely mobile uterus, unlike the previous case. But the only problem is that I had decided for abdominal because of the position, change in the position for that. The rest of the procedure is absolutely normal. 42 years para one with pelvic endometriosis. Right chocolate cyst ovary 12 centimeter in diameter, failed medical management. And this is planned for lap hysterectomy. You see, these are the cases. There is a definite place for lap hysterectomy. When you put a scope, you find that the left ovary is buried, and left ovary is relatively normal size. It's not very big, but it is fixed to the posterior surface of the uterus. But on the right side, there is a big chocolate cyst, and in the midline, the gut, you can see the gut completely adherent to the posterior surface of that. And these are the cases you have to do a laparoscopic hysterectomy. And laparoscopic hysterectomy is of very, very beneficial role in this particular case. And you can do a total laparoscopic hysterectomy, or you can do a laparoscopic assisted vaginal hysterectomy. I think the laparoscopic assisted vaginal hysterectomy, these things can also be done to save life. But here the posterior dissection is there. If you want a posterior dissection, I think the rectosigmoid, either you can do it, dissect it from below, or you can dissect it from above and then do the job for that. But the two adnexa, you can dissect it, and under vision, you can dissect it, and there is definitely a place for a laparoscopic hysterectomy in this particular case because of the adnexal lesion of endometriosis and adhesion to the dense adhesion to the rectosigmoid to the posterior surface of the uterus. You just separate it and then do the procedure. And here the extraperitoneal is option for yours. Extraperitoneal is not necessary, not very important, because we can dissect it, the whole of these from the medial to the lateral, and put I think the vessel sealer and the infundibular pelvic approach to the infundibular pelvic can be much more easier. And after that, you can do the procedure with that. And the lot of vessel sealers are using, you can use the harmonic for that also, but the dissection is much more important. You must go to the proper cleavage for that. And lap hysterectomy is possible for that. And here the central part, you have to dissect it from the more pressure has to be given towards the uterine side, not towards the rectosigmoid. Otherwise, you'll learn. And no, I think electricity, I think the current, you don't apply that. Otherwise, you land in problem for that. And after clearing all these, the whole procedure can be very well easy. And the dissection is much more important. You clear everything, the whole pelvis. Now you can see the whole of the POD is cleared for that. This is the important part of this procedure. And after the clearance of the part is there, then the things becomes very easy. You need not worry about it for that. So primary attention is a dissection and cleaning of that ovarian cyst and the tumors, and particularly the rectosigmoid part. And you can apply this is a bipolar forceps which can apply it. You can use the vessel sealer with the cauter, or you can use the harmonic also for that. And all these are good, and as per your own choice, you can have it. But hysterectomy can be possible for that. And this is what I meant to say, that the dissection is more important than ultimate removal. And if this dissection is up to, you can clear the rectosigmoid and you go all throughout, and then laterally and then go for the uterovesical fold of peritoneum, dissect the bladder, go down, and you complete the procedure of hysterectomy. Either you can do here, the option is you can do the TLH can be done very well here, and also you can do laparoscopy, LAVH also you can do as per your choice and your expertise for that. 45 years para 2, both spontaneous vaginal with pelvic endometriosis, persistent pain abdomen with menorrhagic cycle. And this is a case where you find that again a case where the whole of the both the adnexa are fixed to the posterior surface and the rectosigmoid like the previous case, and this is to be separated with that. The other side is relatively better, it's just fixed with that. And this is the thing which I say, that the clearance of the POD and the adhesions, the first beginning, then the uterus is not very big. Now you can do the two procedure, either a TLH can be done, and in this case I've done a TLH for that because I am always in favor of LABH in this type of cases, because that is much more easier, and technically and complications wise the ureteric injuries and other things are less, and more so the concept of this LABH is definitely part abdominally, part from above and part from below. But this case, for demonstration, I've shown that this case I've done for the TLH for that. And colpotomizer, I'm using it and dissecting it. But the only thing is that go through the proper cleavage for that. Now, this is a case, para 1 LSCS, 42 years, AUBE, sonography, bulky uterus fixed to the parietal wall. And on midline, scar is wide, perspiculum cervix. You see, this is the scar. I will show in the first picture that I am pulling the cervix. You find the dimpling in the scar, and this dimpling in the scar notifies that the uterus is fixed to the uterus. And then I put this telescope, and in laparoscopy you find that yes, the whole of the uterus is fixed to the anterior parietal wall. I'm going for a dissection, and then again these are the cases where the ideal route is laparoscopy for that. This is a case laparoscopy with extensive abdominal pelvic adhesions. They are all extensive abdominal pelvic adhesions, which needs a previous surgery is there, and therefore you do a meticulous dissection of this momentum first, and then this I'm using the vessel sealer with the mechanical cutter by Martin. It's very good that the same sitting you just seal it and cut it with the mechanical cutter, and you just from the below the umbilicus extensively there is an adhesion right up to the pelvis to the uterus. It is fixed, and therefore it can be very well done with that. You can do it with the harmonic also and complete the. But a good dissection eliminates. You see how the momentum is fixed to the whole of the uterus, not only the anteroparietal wall, but the whole of the uterus. It is fixed to it, but the uterus is not very big, but the adhesions are there. So these are the cases. Don't attempt a vaginal approach and ventrification and other thing. Although some of the cases of undiagnosed case, I have found that ventrification is there with much more difficulty with that I have completed the procedure. But I think more rationality is a laparoscopic approach. The adhesolysis is there, and this is the most difficult part in laparoscopy. And then after this is completed, you from all around the adhesolysis is being done. Then you approach the infundular pelvic and seal it for that. The whole of the infundular pelvic also there is a complete adhesions of this momentum for that, and this is very, very important to separate it. And this is an advantage of a laparoscopy in this particular case, because you can completely lyse it and in the proper under vision, and the anteriorly you just lyse it, extensive vision, free the adhesion from the uterus and adnexa, and then approach that. This is the line where we go it and take a precaution, take a very important thing. The bladder at times are very close to that, and even you undiagnosed entry to the bladder is can be there, and one angle it could be dragged with that. Be very gentle. That's why I dissected it first and then put the vessel sealer, and this is a very good vessel sealer come cutter by Martin, and this is very good, and sealing is absolutely fantastic. and complete the procedure after adesolysis. Rest of the thing you can do it with either a TLH or LAVH, whatever is the choice is yours. But you see the extent of adhesions here all around, how this has been there, and be cautious to find out the undiagnosed bowel injury also. So here be very meticulous that whether the bowel is incorporated there, you see after dissection, then you go for that. And this is how you go stepwise and complete the procedure, free the uterus from the adhesions, and then things have become very easy for that. So these are a previous surgery due to some surgery. This is the adhesion which has been found. It's not due to the cesarean, but this is something else, a surgical operation which has given rise to this sort of extensive adhesion for that. But the basic principle is that a good dissection and a meticulous plane and preventing the injury to the bowel and the viscera, and that is the main aim of that, and that is the technique which you adopt with the different technology which is available for that. And now you think that whole thing, the uterus is dissected out, the adnexa is dissected, and the ovaries and tubes are again adherent to the uterus, and you can do the job. Posteriorly, there is only the adhesions here, and you can again do the job by the same procedure of applying this vessel sealer with the cauter. And remember, you stretch it on one port instruments, you stretch it, see that there is no vital structures for that, and then go to the proper cleavage. And after that, things becomes very easy. And when the adesolysis is completed, I think the same procedure we can go it for the laparoscopic hysterectomy. And now you can see the POD. POD was not visible now at that time. After this dissection, the POD can be seen very well. It is free, and then the adnexa are free. And now it's a very simple job to do the procedure of the rest of the things for that. This is a case of mammoth ovarian, about 30 to 34 weeks of size of cystic tumor, and it's a case of 40 years, Paras lady, Para 2, both spontaneous delivery. And one of the important is the preoperative assessment. And preoperative assessment not only by ultrasound, color Doppler, the CECT, MRI, you do it to mainly the color Doppler and then biochemical markers, the tumor markers. And luckily there is a cystic, large cystic lesion. There's no evidence of free fluid. Then I attempted for the, instead of abdominal hysterectomy, I decided for the laparoscopic route. The patient was also very keen, and he was sure that it is not completed. It cannot be done. But you see how I have done that. The possibility of risk. The only question the oncologists ask are very, very scared that spill is there. The spill particularly, therefore I say that preoperative evaluation is important to find out that there is nothing. And luckily there is it comes out to be a mucinous contents and mucinous cystadenoma, large. The mammoth tumor are always mucinous rather than the serous. And after that, the things are very easy. And when the collapse is there, the whole ovarian cyst is collapsed. You find that uterus is normal. The other ovary, you just inspect it. It is normal. Evaluate the whole of the pelvis and abdomen, the omentum, and the liver and everything for any evidence of abnormality. We didn't find any evidence of any abnormality. And then we go ahead with that and did the complete procedure with the laparoscopic assisted vaginal hysterectomy. Here, the only thing is that fear of malignancy. So fear of malignancy and the port placement. So therefore, immediately you know that when there is a 32 weeks, you can put it the whole thing, the varus, and just drain it out after collapsing, after evacuating the about 50% of the cases when the abdomen is absolutely shrunken, the fluid is shrunken, then you can put the port. There is not a problem for that. And the same thing with the instrument, either with the harmonic. This I'm using the same Martin instrument of the sealing and as well as the cutting, the MAR plus, and this is a 5 mm instrument which is very good in sealing, and do the procedure on the one side, and the other side is very easy for that. And this particular procedure you can do a TLH also, but I decided this case to do a LAVH because I find that the laparoscopic assistance LAVH in some cases are very important for me. And this is the other side which is there, and therefore in some indications of especially when I find that the uterus has to be removed from the above by a morcellator, or there is no space from below because of the limitations as we see in the mentally handicapped or nulliparous, when we cannot find a space. Nulliparous is not a contraindication even for vaginal, but in some cases you have to decide that there is no space there. I always say that the TLH can be done and whole thing can be delivered by the morcellator. Otherwise, these are the cases best suited for that. The urinary complications is list, and as a vaginal surgeon, as a gynecologist, I will definitely prefer them. In this particular case, I have subjected for that. This is the vaginal part. After the abdominal part, you see the vaginal part, and then the posterior pouch is opened, and posterior pouch is open by the straight cutting, and you can see the whole of this pouch is open at one cut, and with the again the vessel sealer, you apply as close to the uterus as possible, the uterosacral and Macken rods. You can use this as a possible, and then the other side you do it, and the second clamp, after the uterosacral maternal Macken rods, the vessels you coagulate, that's the most important. And of course, the other part has already been dealt with by the laparoscopic approach. As soon as you cut it, whole thing will come out for that. And you see the anterior pouch which come out just by pulling everything, the whole uterus will come out for that. And this is the normal ovary and the tube. And then you can see the other ovarian cyst, a big ovarian cyst, and it will come out automatically because it's already shrunken, and you just give a traction, and slowly whole ovarian cyst can come out for that. And the whole procedure is over now, and you can now do a closure and then inspect it by laparoscopy that yes, we have done the job for that. So there is definitely a place in, even if impossible, you think that it is impossible, it is possible, and you can do that. And vault closure and the vaginal closure is to be done from below, and then subsequently you can re-inspect and find out that there is no bleeding and absolutely normal for that. This is another case, LVH. This is another case, a previous LSCS, a vaginal hysterectomy, purely vaginal hysterectomy. I want to devote more of time to the vaginal hysterectomy because I have already one episode on vaginal hysterectomy. Just to complete the procedure of the three different varieties. This is a case of previous 2 CS, previous LSCS. LSCS is not a contraindication for that. I'm using this, another instrument is again a vessel sealer by Martin. I'm using this, and this is a very good thing that you go close anterior pouch, posterior pouch, don't open the peritoneum. And ideally, initially we were opening the peritoneum earlier, but now we are not opening the peritoneum. And with this instrument, at the level of the uterine is very meticulous that you don't go laterally. And always closer to the uterus will eliminate many things, and all of the complications are avoided by that. And that is important. What I find that you apply this in the second part is the bundle, uterine bundle, and don't have to skeletonize everything. And remember that always if you go closer to the uterus at one point of time after the uterine, the anterior pouch will be automatically open for that. And that completes the procedure. The upper pedicle, you have to remove it. Same thing with the same thing, but you can apply a clamp also and then reduce the space. The clamp is not for suturing, but reduce the space, you can have it, and then whole procedure you can complete it at the end. And posteriorly you must deliver it. And a big uterus, you have there can be debulking, or if it is a myomectomy, myoma, you have to do a myomectomy. It's much more easier. The bigger the adenomyosis uterus, the debulking procedure is a little difficult, and scalpel debulking procedure morcellation is much more used, and we are gradually we are using this particular case because this is a previous cesarean. At that particular level, you must be very, very careful because the vessel lateral entry is there, lateral window is there, but the midpoint is completely fixed. So precaution has to be taken on the midpoint so that the bladder is not very much densely adherent for that. This is the only trick we are in previous cesarean we made it, and therefore previous cesarean is not a contraindication for vaginal hysterectomy. You have to be going to the proper cleavage in the lateral part and then come to the center, and this is how the total vascular pedicle is ligated for that, and how I'm going more closely to the uterus and rather than laterally. If you go laterally, there is a chance that you are subjecting to the ureteric injury for that. And then it's a big uterus and it's a bisection. You go for bisection and intramural coring for that, and then do the procedure because the fundus is a bigger part for that after the uterine arteries become ligated, and this is a big, about 12-14 big size uterus can be delivered with the previous cesarean section also. This is another case with the multiple myoma. This is way back in 2007 we have done it. This is a big uterus with all, at that time I was little younger because it is about 15 years before, and I dared to do more difficult cases at that time because now I have a little more of experience. But the thing is that because of the age, your reflexes will come down. I don't know whether my reflex will there or not, but I'm continuing to operate now also. So this is a case where it's a 24-week size uterus with a multiple myoma. So it's a 24-week size uterus. People say that it's not worth to do that, the vaginal hysterectomy, but the patient was not prepared for abdominal and neither for laparoscopy, and he insisted that you do the procedure by a vaginal procedure because one of two of our relations have done that and they were very happy with that. And I with all 24, 26 week size uterus with multiple myoma, this is the case where about 15 years back I had done that. And with this machine, at that time I was using for last, at that time 2005 onwards, I was using this machine for that. So I thought, let me try with this multiple myoma and take an adventure of it. And that's why I wanted to share my adventures to you people for that. So this again, at that time, the IQ was not available. This clamp again was designed by me. I told that, yes, we will do the power setting. The IQ model is little better than that. Now we have modified many of the power setting and the hand instruments for that. So basic thing is the myoma is that go to the proper cleavage, and myomectomy, go to the proper plane of cleavage. And now when the plane of cleavage is thin, and the myoma screw can be of great help, and you apply the myoma screw, and the myoma screw you apply in the middle part, it is there, and just give a traction for that. And with that, if you are going to the proper cleavage, it will come out very, very quickly. So the cleavage is important for that. So one big myoma has come out for that. And again, you go and more, and I find on the right lateral wall, there is again a myoma which I can see with the cleavage, and with the again the myoma screw with the traction and counter traction. You deliver the myoma and complete the procedure as I just giving with the pressure, with the traction and counter traction, with the guidance, with the my scissor and the cat's paw giving a traction. But mainly you find that when you find a good plane of cleavage, that is good. Otherwise, if you do not find a cleavage, I think the bleeding will be less and you cannot deliver in a proper plane. Now, this is a good plane which I find, and then giving a traction slowly, such a big myoma can be delivered with that, and that ultimately gives rise to a complete procedure. As I give a traction, more and more myoma tissue come out for that, and therefore this is the second myoma which has come out for that. And after the space is found out, then before, because the uterine is not dealt with, now I'm putting the uterine, I'm getting a space to find out this, the uterine artery. Can you see that uterine artery? And then after that, you go a little above, and again I find 2-3 myomas there, and which I can just deliver it because it's such a big myoma uterus. But I feel that myoma uterus is easier than adenomyoma, because in adenomyoma you have to go for a debulking procedure by very methods which takes a long time, and in a scalpel myomectomy, my scalpel morcellation is there. I'm finding a good morcellator could serve the purpose for that. But basically, if you have patience and surgical expertise and little skill, things becomes very easy, and you can do many jobs for that. And now you can see the again you can go sideways and put a clamp there and deliver always with the posterior part, because posterior there is a space. And again, I find that in the posterior part also, still one myoma is there in the fundus. And again, to avoid, to get more space, I'm getting a space, I can apply that. But if you do a myomectomy here, the space is again, I find that is enlarging, so that in the upper pedicle, I can put a little clamp for that and remove it. So that this is the way I do that procedure. And believe me, the decision is yours. The technique, you must develop it, and you can do much better than what I have done it in presenting during the couple of few videos, which I'm demonstrating that. There are many more cases, because of the time constraints. I have not kept it all varieties. There are typical things which you can do it for that. And whole of the procedure, I'm not able to show in all cases, but I think whatever the techniques where I'm using it, all of you must have used also. And I will share some of my experience in this particular video for that. So at the end, the upper pedicle is clamped and the whole uterus can be out for that. And you can remove the ovary within that also. People say that ovary and removal is necessary, then you apply laparoscopy. No, it's not that. The same procedure in ovary and removal also, you just first tackle the round ligament and then go through the infundibulum pelvic, and you can enter into the infundibulum pelvic and complete the procedure for that. If the ovary is retained, then there is no problem. You can just coagulate on that. So this is how to do it. And after the procedure, you can have a closure of the vault, and basic emphasis is to given on the two vault angle for that. So ladies and gentlemen, and my dear gynecologist, thank you very much for giving me this opportunity. I have crossed beyond town, and that's why I thought I must close it. And again, for the access from the initial part, I again thank the team Juventus for giving me again opportunity for this presentation today in to Alad, and Dr. Diwan has already conveyed you for the how to get a link and get into it. And now I request Sanjay, Dr. Sanjay, to again remind the access, and YouTube channel also, they can enter into it without link also. Sanjay, please.
Yes, sir. Thank you, sir. So this was the 24th episode. So now we have started as a Pracha Hospital and Juventus collaboration. We have started a YouTube channel where you will get all the 24 episodes of all the knowledge, whatever Dr. P C Mahapatra sir shared with you, you will get at a single click. So the episodes will be 1, 2, 3, 4, 5 like series, and you can watch one after another, and all episodes will be at one single place. So this will be Dr. Mahapatra's channel. So and there will be for that, if you want to get the notification or you want to get the any further information regarding the new episodes, you have to subscribe the channel so that you will get the all the notifications. So this is how we have started the channel. Thank you, sir.
Thank you, Sanjay, for this particular thing, viewer and all that. And I think as a teacher, and I'm a passion for teaching, and you people love so much, and the love and affection has yielded this type of expansion of the educational program, and that's why we are continuing. And I'm surprised that by this time 24 episodes is already finished, and I really thank all my viewers and my lovable persons for that, and thank you very much for giving me this opportunity for that. Sanjay.
Thank you, sir. Sir, there are few questions, so with your permission, we can take few questions. So the sir, Sheikh Muhammad from Anandnag, he's inviting you to the beautiful valley of Kashmir. Please, he's asking to accept.
Certainly.
Yes, sir.
I will certainly go.
Yes,
I have
sir.
assured you, I have told you, I promised you.
And his question is there any medical management for diffuse adenomyosis other than hysterectomy?
Well, diffuse adenomyosis, there is a medical management for ovarian endometriosis. But for adenomyosis, we have tried many drugs like cabergoline. We have tried like the the letrozole derivatives. I have tried with that, but I'm not very happy with that. And I've tried the LNG IUS. And the GnRH analog I have tried also. Those want pregnancy, fertility before the ovum pick up, 2-3 doses of leuprolide depot injections. And if they are having a child and pain perception is there, the LNG IUS can be of great help, particularly for that. And of course, per pain relief, Dynogest can be an option for that. But believe me, these are all promotion of fertility. It is not very important for that. And only for a localized adenomyoma, the place for surgery is there. Otherwise, the medical management will be a priority for that, for pain relief. For infertility, I think it's $1 million question to be seen for that.
Yes, sir. Sir, there is a question from Nirujogi Chandra Prabha from Vishakhapatnam. And she is saying, good evening, sir. Excellent presentation. And the question is, I would like to know your advice regarding uterine artery embolization, lightening uterine artery after delivering the baby. In a case of multiple fibroids complicating pregnancy, in a case of post-myectomy pregnancy, in spite of taking all precautions to prevent. What is your experience, sir?
I didn't have any experience on this particular thing in pregnancy. But myomectomy, I have experience of uterine artery embolization, particularly either in unmarried or in a case of infertility. And once upon a time, it was told that yes, it is contraindicated when pregnancy is there because it's affecting the ovarian disorder. But later on, many studies have shown that it is not absolutely contraindicated. It can be given for that. So my experience on that, it gives a reduction of the size of the myoma to at least not more than 50%, and it is a temporary procedure also. So it is temporarily, it can reduce the dimensions, it can have a well-being for a small temporary period of about 3 to 6 months, but it's not a particular solution for that. Regarding the pregnancy, I don't have any experience on that, and therefore during pregnancy, there are literatures which shows, particularly in the case of placenta previa, central placenta previa, before surgery, you go for the embolization and then do that so that the bleeding will be less. In fact, I have many cases of placenta previa which I have handled, and I pray God that I didn't find any such problem for that. The bleeding is more in some cases, only in cases where there is a previous 2 cesarean section with the placenta previa. And in Creta, I decided immediate doing a hysterectomy because they have 2 babies there. I immediate hysterectomy in the same thing, rather than waiting for that and alternative methods of uterine artery ligation or embolization for that. So this is an option for that. But simple uterine arterial embolization and then doing the procedure, I didn't have any experience. There are people who I've seen the presentations where in facilities where they're existing, they go to the cath lab and do the embolization and then come to the OT and do the procedure for that. And in fact, whatever procedures you do, hardly we get a problem. In cases where you are prepared for that, take a blood and immediately tackling the bleeding during surgery is most important. And peculiarly, I find when you are more cautious, I think the complications are less. The complications are more often when you don't expect that, and in a very simple case, there is a complication of bleeding for that.
Yes, sir. That's all. Thank you, sir.
Thank you.
Thank you very much, sir.
Thank you, Sanjay, for giving me another opportunity for that. And thank you for the YouTube channel we have inaugurated here. And I think it's a boon for the gynecologist who want it and to take up this. And thanks for the love and affection of all the audience and viewers. Thank you.
Thank you, sir. Please stop the recording.
Thank you, sir.